Now, let me just tell you some constraints because of the short announcement of dates of interview. Many subjects interview are overlapping. So the mock interview sessions have been tried in such a way that everybody gets equal chance. So unlike before, where we had a lot of time to discuss with each student and see and then discuss each topic in detail, this time I think we would not be having that kind of a time. So what I have done is whatever information is helpful to you guys, all those things has already been shared in our group. Now it is a brief discussion just to tell you guys how to be more confident, how to be calm, how to think and classify and answer your questions if feasible. This is our target. See, now the session is constrained by time pressure. We would have to end whatever and wherever we are at 9 p.m. So now we are going to start at say 7:30 right now. Okay. So that is the thing which is different from previous sessions. But again, if you feel that again a session has to be done tomorrow concerning some specific topic, we can do it. But I will tell you, you guys know most of it that you guys have to know. Congratulations for reaching up to this stage, which is really, really important. And I know that pretty good number of students here already are also parallelly messaging me telling that NEET SS rank is also fantastic. So you guys are deciding between different colleges, but still have managed to get till here at this stage. So do not be confused too much. It is a session just to give you an idea. I would be more happy if each person is able to talk it out briefly, and then tomorrow you guys can see the important questions and answers for each of them and try to be more confident and present yourself good before the exam. Don't get too much tensed in the group. Please make sure that each of you know in the day it will be a different time, so make sure you are in a place with very, very good Wi-Fi. It should not happen that you are in a place where only your phone was the only source, but then there was no power for almost 2 days, this and that. Okay. Most important thing, always remember, all of you have 80% of your rank decided based on your score on your theory. 20% is going to be decided based on your current interview round. Okay. So it will be predominantly your existing rank plus or minus a few. Okay. It won't be a major difference in your existing this thing. So give your level best so that you have that all the 20% marks coming over from your interview also. So right away, let me start screen sharing, guys. Now, usually I add things from previous years. That's because we don't want to miss out on anything that was asked. So again, tomorrow I'll be asking 17th or 16th, I'll be asking you guys, and each of you will be messaging me what exactly was asked. That way we'll be able to compile a decent number of add-on topics to this existing slide. I've tried to make it as simple as possible. Let me just try to, minimize my screen. Let me open the chat box so that we are very clear and I know what each student is expecting out. Okay. So totally, yeah. So for the interview session, what I would say that is what is being tested? What do you think is being tested? It is your approach to clinical situations. Now, what students have told me currently is each time we tell them important topics, some or the other things come from one of these topics at least. Rarely they may get an out of the box topics, but then that is when that's a very rare situation, or you must have been so good, you have impressed them so much to really go to that level of questions. Okay. So can I have a thumbs up to start off? Because each time I see now new students are joining. So I'm not sure if some of you have missed. Yeah, thank you. Thank you, Dr. Sanjay, Dr. Suhail. So we'll keep in touch. So the deadline for current discussion is next 1 hour, 20 minutes. Okay. So yeah, thank you. Thank you, Dr. Priyavarth. So first thing is, I'll be randomly putting out some names and each of you can start off with one discussion. Okay. Yeah. So the first thing is the approach wise, what has been tested, the topics I have put up in the group already. It goes on from dysphagia, upper GI bleed, gastric outlet obstruction, extrahepatic biliary obstruction, And then you have pancreatic topics, which includes both acute and chronic with complications. Then comes hepatomegaly, splenomegaly, and mass per abdomen questions. Then comes liver, specially with respect to management of special situations like hepatitis, complications of CLD, ALF, ALF management has been asked. And then here I would like to add one topic, that is Budd-Chiari syndrome was asked almost last 2 consecutive years. So know how to manage vascular disorders of liver. Okay. Then comes chronic diarrhea, management of malabsorption is again important. Now, inflammatory bowel disease, it may be just a passing question. There may not be a perfect case just based on these. Last comes approach to constipation and its different differentials. So these are the basic topics. Then when they asked question, many times think about special scenarios like pregnancy, elderly, and pediatrics. If there is something different that you might have to do at different scenarios. Okay. So then always remember, they love students who are inclined towards research. Okay. So inclined towards research means they don't want people who are, completely against research, because they want significant trust in research work also. So they will ask you questions with respect to research topics. And most likely some students have even got questions from their previous theses. So know your theses well, and be ready for questions on them also. So first thing is a simple topic, dysphagia. Now, what is dysphagia? Can I have Dr. Suhail? I'll give you a simple scenario. Are you with me?
Yes, sir.
Hi, Dr. Suhail, your voice is low, or I don't know what is it. Let me increase the volume from my side. Yeah. Am I audible?
Yes, sir.
Yes, thank you, Dr. Suhail. There is no echoing, right, from my phone or something. I'll keep everything distant.
No, sir. No, sir.
Excellent. Congratulations, Dr. Suhail.
Thank you
Happy
so much.
that you are here up to this level. Now, dysphagia is an important topic. I have a 60-year-old male presenting with progressive dysphagia, initially to solids, followed by liquids since last 2 months with significant weight loss. How will you approach the case?
Sir, as the patient's age is 60, elderly patient with progressive dysphagia, first to solid and then to liquid, it can be a malignant cause, sir. So, in this case, first investigation I will do is upper GI endoscopy.
Good, excellent. You had the ability to summarize what you have heard well. That is fantastic. So you should be able to summarize what they tell and tell your etiologies, which is very good. Third, investigation wise, spot on. You had the best investigation that you should start off with. Always remember, also, always when talk about investigations, you should be able to tell, apart from routine investigations like hemoglobin, liver functions, fitness for procedure, the best test I would want to do is an upper GI scopy. Added
Yes.
later, based on the lesion, if I see anything, I might do biopsy. Okay.
Yes,
Then
sir.
they will give you a picture suddenly. This is what has happened last time. Next question will be a picture on endoscopy with some lesions
So your
seen.
voice is breaking in between.
Is it happening to everybody?
No, sir. No, sir.
Hear a
No,
few
sir.
lines.
What I suggest is all of you mute yourself so that it becomes clear. Okay. Because I am in a place where the internet is quite good. So if there's any connection issues, I will definitely look into it. Okay. Fine. Some echoing is there. Somebody has opened their this thing. They have not muted. So that is the issue. Yeah. Next is a similar scenario. I would like to ask Dr. Priyavarth Goel about same situation. They might ask you much younger, 20-year-old presenting with chest pain, dysphagia, not able to differentiate whether it is solids or liquids. For both patient has similar issues. What is your approach? You can unmute and talk. Dr. Priyavarth. I think we have lost his connection. So, Dr. Suhail, how would you want to go in a different scenario?
Sir, this is a young patient with dysphagia to both solids and liquid,
Yeah, chest pain.
associated with chest pain, sir.
Yeah.
Sir, in this case, I would like to ask the history of the starting event, sir. Whether it was for liquids first and then followed by solids, sir.
Okay.
In
Fine.
this case, sir, I would my first differential would be ecclesia cardia.
Okay. So always have the habit of classifying your problems. Okay. I would like to consider a malignant cause, most likely mechanical obstruction secondary to this. I would like to consider a motility
Benign.
related cause. How do
Okay.
you know it is achalasia? It could be Jackhammer's esophagus, right?
Yes, sir. Yes, sir.
It could be hypercontractile esophagus. So wherever possible, try to classify your answer. This is second most important. Other point I would want to tell you. I will reiterate it later. Please classify. Okay.
Yes, sir.
Classify your answers. Okay. Next, they might show you a picture of manometry. You guys should have already known how to, evaluate manometry. I will tell you few classifications that you should know. What is Eckart's classification? Eckart.
Clinical
First,
score for achalasia cardia.
To assess the treatment response, or whether the patient is responding or not in
And also for staging as well. Staging of achalasia cardia as well.
Post surgery response to treatment
Response,
is assessed, sir.
even before surgery, you have a subjective value for it, and post surgery, if you have a subjective value, then you know that objectively, if it is a reduction, this is an objective test, and know its variables. Eckart score is a tentative question. Okay.
Yes,
Next,
sir.
Chicago's classification, and a new classification has come up. This I hadn't discussed before because it's still new. What is it apart from Chicago's classification for manometry? Come on. London classification. Okay, guys, London classification. See, note it down, read about it. 1 or 2 lines, more than enough. Okay. London classification. Next, one of you have asked, what is the first investigation for achalasia? See, whenever you are considering achalasia or a motility related disorder, and if it is clear cut, then motility test is the best test. But upper GI scopy to rule out mechanical cause is the best test for dysphagia anytime. First test. Okay. Some older books have mentioned it as barium swallow. That will just add on to your diagnosis of motility disorder. But then to subclassify, you have to do an motility test, that is manometry. Okay. Am I clear? Okay. Next is, so you know Chicago classification, London classification. Write it down. We can discuss in the group if you guys are still unclear. Next is, whenever there is dysphagia, okay, don't forget the differentials of GERD. Grade D dysphagia can always have dysphagia and sometimes even odynophagia. So these can be related questions. You can have an achalasia cardia with stasis-induced esophageal candidiasis. So these all are, you can get more than one diagnosis in a patient. So be able to identify some good pictures of upper GI scopy with candidiasis and with a grade D GERD. So what is the classification you use for GERD? Identification of GERD. Any classifications you guys know? Los Angeles. Okay. Any other classifications apart from Los Angeles that you guys know of?
Lyons.
Lyons consensus is a very important question that you should know. Lyons consensus. Okay. Yeah. One more endoscopic classification is, yeah, I know. Lyons criteria. It's not classification, but no, it's a question. One more classification is my question.
Excellent dent.
Have you heard of Savary Miller's classification?
Yes, sir.
Yes. Know the names. Know the variables. What is its slight difference between Los Angeles and Savary Miller's? Okay. Okay. Next. GERD, that is enough. Approach, they may ask you, how do you differentiate between NERD, then erosive gastroesophageal reflux disease, reflux disease, or reflux hypersensitivity, and functional heartburn? How would you be able to differentiate between these subsets? Any test of choice?
pH manometry.
pH
Yeah.
manometry.
Yes.
Then
pH
Mr. Story.
manometry is fantastic. I'll give you a situation. Patient is already on PPI. Is pH manometry going to be helpful or something else?
Impedance manometry.
Yes, you add on an impedance manometry. What is the advantage of impedance manometry?
Non-acid reflux.
Also can be diagnosed.
Weak reflex.
Excellent, excellent. So, no, see, they'll go to one step. They'll next ask you questions. Okay, so PPI, on PPI, off PPI, you can still have which is better. So, impedance manometry is again an important question. So, you'll be able to diagnose non-acid reflux also. How will you know whether a patient has reflux hypersensitivity?
It's correlating with the symptoms.
Yes. Which symptoms? Where do you get these symptoms? Yeah, when you are doing a 24-hour pH metry, you tell the patient to press some buttons while he gets sleep. There you have something called a symptomatology index. Okay, that if correlates well with the reflux episodes, you diagnose it. Okay. If there is no relation between symptoms also, but patient complains of heartburns, then the diagnosis of at last after exclusion, it becomes functional heartburn. Simple. Yeah. So questions that you have to go through again, classification wise, is Lyon's consensus. Okay. Next, upper GI bleed. An upper GI bleed is a very, very important question. One, because your temperament, your approach is being tested here. So I'll give you a situation. Dr. Manikanta, are you with me?
Yes, sir.
Yeah. An upper GI bleed means a patient, simply they'll tell you, a 40-year-old male had a binge of alcohol, had a retch, followed by hematemesis. What is your approach to this patient?
Sir, since patient is having upper GI bleed, sir, so first step is always stabilizing the patient, sir.
Excellent. First is stabilization.
Airway, breathing, and circulation we have to maintain, sir. We have to keep the 2 large IV bore cannula and start the IV fluids. And pantoprazole drip can be started, sir. 80 mg IV start and at the rate 8 mg per hour infusion over the 24 hours. And HB should be sent, sir. If it is less than 7 gram per deciliter, we have to transfer the blood transfusion, sir. And simultaneously obtain the history as well, sir. So in this case, as there is a after retching and his binge alcohol intake, I will think in terms of Mallory stare as a first differential diagnosis, sir. However, simultaneously, since he is also alcoholic, I will do the per abdomen examination, also look for the icterus as well, sir, to rule out the varicose.
To rule out portal hypertension.
After that, if the after stabilizing the patient, we can perform upper GI endoscopy, sir, within 12 hours for upper GI bleed. Actually, sir, within 24 hours for upper GI bleed, for 12 hours for varicose bleeding, sir. If it is showing only Mallory stare and no bleeding, we can simply discharge the patient, sir. And if it is active bleeding is there, we can go for endoscopic therapy can be done, sir. Such as hemoclip or cautery, electrocautery can be done. Still not control, angiography embolization, still not control, we can go for gastrostomy and overseeing of the blood vessels, sir.
Excellent. So you've given a very good idea of what if and what if not. That is excellent. So only thing is, it was a good way of telling your approach. You have, one is you have summarized the condition and then told what you are thinking about. First thing comes is, I would like to stabilize the patient. Don't forget it, because they are waiting. Where is that stabilization? CPR, whether this guy is giving fluids, 2 large bore IV cannulas. These are the words they are looking for, which are basic medicine. They are not trying to see whether you know NBI scoping, what are the different types, what is the vessel, this, that. Okay. So that is what you have to understand. So Next question, in a similar scenario, they will next show you a picture and they'll show you an ulcer in duodenum. What is the classification you use for grade?
Forest classification we use for ulcer, sir, to prevent the risk of rebleeding, sir. We have 1A, 1B, 2A, 2B, 2C, and 3. Endoscopic therapy is recommended as per ACG, 1A, 1B, and 2A. 2B, there is no defined recommendation, sir. For 2C and 3, there is no need of any endoscopic therapy. If it is 3, it is clear base. We can discharge on the same sitting, sir. After endoscopy, discharge on a same sitting with a daily PPI. For 2C, we have to admit the patient for 1 to 2 days. Clear fluid should be given for 1 day. After that, we can discharge the patient on regular diet and daily PPI. If it is 1A, 1B, 2A, we have to do the endoscopic therapy. As per AC,
Go on.
As per ACG, the recommended endoscopic therapies are bipolar cautery, heater probe, and injection of absolute epinephrine and ethanol can be considered. After that, clear fluid should be given for 3 days, and intensive PPI should be given for 3 days, and discharge the patient on regular diet with PPI BD for 14 days. After that, after 14 days, we can change the patient on once daily PPI. For 2B, we can either go endoscopic therapy or we can leave alone. There is no defined endoscopic, whether ACGs has not given recommendation.
So what I am telling you is, once you know some part is controversial, don't get into much depth about that. Okay, first thing. In
Okay,
2B, you have a clot. Some studies tell you remove the clot and then do the therapy. Some of them tell that you just wash out and wait, or sometimes don't do anything. Okay, so when you have controversial thing, do not worry. Best is to do an endotherapy. Know what is dual endotherapy. Second, there are newer things apart from cautery, apart from adrenaline injection, apart from clips. There are newer things. Any newer ways of hemostasis that you can achieve?
TC 325 hemostatic powder.
Okay. Anything else?
Monopolar argon plasma coagulator.
Argon plasma coagulation for APC is for game and few lesions, not routinely. What other things you can? Any improvements in clips?
Or the OVS.
So, if a lesion is big, you have bigger, clips. One of it is called Ovesco, but there are newer ones coming up. And then what I really wanted from you was hemospray. Okay, hemospray, there are multiple types. What you have told is a single example only. Know their mechanisms also. Sometimes Mallory Weiss, we can do even band. Okay, band also we can band and cover it up so that entire thing is nicely gripped in. So there are various ways of endoscopic management. The standard ones should be known. Okay, and then timing of upper GI scopy, like you have mentioned. If clinically or by tests there is features of portal hypertension, I would preferably do the upper GI scopy within 12 hours or else up to 24 hours time is there. Next is hemoglobin goal. What is your HB goal? If a patient has coronary vascular disease and if a patient has nothing, no comorbidities.
Without comorbidities, the target is between 7 to 9, sir.
Okay. With comorbidities?
9 to 10 with cardiovascular disease.
Yeah. Okay. I would say you can stick to a single point. You can tell the target is 7 if there's no comorbidities, up to 8 if there is cardiac. You can give a single value instead of a range. But of course, if you have a range, you can 7 to 9 is a huge range. Okay. There are studies which has told that restricted transfusion is enough. No data on that, and you should be able to talk about it. Is that fine?
Okay.
Target is 10 in CAD.
No, 8.
Okay. Less than 9 with transfuse.
Yes. You can. Your target can be 8. Okay. If your patient has 7.5 HB, example, no comorbidities, you don't need to do anything. Do an upper GI scopy, do the hemostasis. If nothing is there, you monitor. That's it. Suppose the same cardiac patient comes with 7.5, transfuse. Got it?
Okay.
Remember simple numbers 7 and 8. 7 for no comorbidities, target of 8 for cardiovascular comorbidities. Okay. Next topic I would want to discuss If you guys have any doubts, let me know. Basically, you should be good at summarizing. Dr. Manikanta, I'm really happy with the way you were able to summarize and go from one to others. Don't be too fast. You should be clear.
Okay, sir.
Sometimes jumping directly to surgery and sewing. If you go that fast to sewing, the next question that they'll ask you is, what are the different surgeries? What is sewing? How do you sew? Is there any endoscopic way of sewing a bleeding vessel? Okay. So
Okay,
what
sir.
I'm trying to tell is clarity, harp more about things that you know. That is, talk more about the endoscopic management, which probably the examiner also knows much better. Okay.
Okay, sir.
Excellent. Next, just suggestion so that you are more careful there, but be confident. That's more important. If you don't know something, tell I don't know, rather than telling her something. Even if you know you don't know, it could be, sir, this may be like that. No, maybe if and buts, just be to the point. Okay.
Okay, sir.
Excellent. Next, can I have Dr. Bharati Mohan here? Am I audible?
Yes, sir.
Excellent. Dr. Bharati, hi.
Yes, sir. Good evening, sir. Hi, sir.
Hi, good evening. Congratulations. Congratulations to all of you. I need not tell again and again, but then this is the last one chance. Let's go ahead. Next is,
Okay.
I'm just asking brief questions to just make sure to give you an idea. Gastric outlet obstruction, if it is the syndrome, what they will ask you is, two kind of scenarios can come. An elderly male coming with history of recurrent vomiting, weight loss. Vomiters is stale and contains previously ingested food. Okay.
Okay. Okay.
This is one scenario. Similar scenario, one more patient comes with recurrent vomiting, has large bouts of vomiting, has stale food. Appetite is kind of good. He's able to eat, but he's vomiting. Some minimal loss of weight. How are you going to approach these two cases?
Sir, initially the patient was having vomiting with recently ingested food. He might be having a GOO, sir, which can be like fully closed. And second patient, fully closed means it is not letting, it's a advanced disease or a pyloric problem. Or a second patient might have some ulcer which is about to go for stricture because he is not having any weight loss or only minimal symptoms he was having, sir.
Okay, excellent. So basically, what is being tested in gastric outlet obstruction in these questions is your approach about the vomiting, about where is the localization. Now, gastric outlet obstruction can be right at the antrum or at the duodenum also, D1, D2 also. Okay.
Yes, sir.
If
Okay, sir.
you have a gastric lesion, remember a malignancy or something like that, the capacity of the stomach is less. There will be pain, there will be weight loss, and the patient will be vomiting. And if near complete obstruction, then there'll be significant weight loss and the patient will not do well. Sometimes also keep this in mind, but they may not test much. Patient's appetite is good, vomiting once in a while means the abdomen accommodation is good. The stomach's accommodation is good. Probably we are dealing with a duodenal problem, most likely a benign cause. Okay. So benign cause, like what you have explained, can be an ulceration with impending narrowing. It could be an, kind of anything. Whenever you have an obstruction, okay, they will ask you, what are the differentials? What are you thinking about? Always think, classify. What are the causes of gastric outlet obstruction?
Sir, it could be right from malignant causes, sir. CA stomach at the pylorus or antrum, and or it can be due to any tumor growth also, sir, or it can be due to benign causes like duodenal ulcer with stricture, or it can be due to gastric ulcer in pylorus, which can also cause strictures, and it can be due to duodenal pathology like pancreatic head CA, or it can be also due to periampullary carcinoma, which includes pancreatic CA also.
Same, I will just answer. Sir, gastric
Okay,
outlet obstruction can be because of various causes, which include some malignant and some benign causes. I would like to classify as luminal causes and mural causes and extramural causes. Luminal causes could be conditions like bezoar formation. Okay, again, bezoar formation are of many types. It could be trichobezoar, pharmacobezoar, or there are various types. Okay. Second, there could be sometimes mural causes, which could be stricture or ulcers, which again can be benign or malignant. And extrinsic causes, there could be some obstruction from external agents, like say carcinoma of pancreas, which is a rare cause but can occur. Gastric malignancies, yes. Then there could be annular pancreas. Okay, annular pancreas.
Okay.
So these are the ways. See, now just by simple addition of classifying, see, I didn't think much, just classifying, I was able to give at least 5 more differentials than you. You are able to tell
Okay.
ulcers, you are able to tell benign cause. That's it.
Benign cause.
You're just beating around the bush. But when you classify, okay,
Okay, sir.
it's easier. Three entire luminal causes were missed, extrinsic causes were missed.
Yes, sir.
Can you tell me one specific type of pancreatitis which can, wow, excellent. Yeah, Manikanta doctor has put off the entire list. But if you classify, it is much easier. Got it? Borvet syndrome. What is Borvet syndrome?
Obstruction due to gallstone.
Yes.
Colon is to the first part of the duodenum.
Excellent. Excellent. So now you know that extrinsic cause, mural cause, internal cause, you can put different causes in each of it so that they know, see, they are testing your thinking ability.
Okay, sir.
Thinking ability is tested. That's what I want to tell you guys. Next. If a patient comes to you with gastric outlet obstruction, do you have any special clinical tests to assess these patients?
So here, do we also say motility causes a strict functional like?
Yes, that's what I was going to come later.
Control manometry.
No. My question, let me see. What was the question I asked first? Special tests to examine this patient. Auscultopercussion, excellent. Scratch test, saline loading test. Okay.
Okay.
Please know them well. That they may ask you, though we don't do it clinically much frequently. Second, when you have causes, always remember the best classification is mechanical cause and motility related cause. Mechanical cause can be any of these which I have explained. Motility related cause is nadir, which what is the most common motility related problem presenting similar way? Gastroparesis. Okay. Then when it comes to gastroparesis, again, there are some causes which we can discuss in due course. Okay. Excellent. So gastroparesis, what are the different types of gastroparesis and what is the most common type of gastroparesis?
Most common idiopathic gastroparesis, 40%.
Excellent. Okay. So now we have included most of the topics from gastric outlet obstruction per se. Let me just see through the chat box if there's something which I have to answer. Yes, most of you answered it right. Yeah. Dr. Vamshi Krishna has added few more diagnoses. Please do not forget caustic ingestion and secondary luminal issues that can happen. Caustic injury itself is an important question with respect to case scenario. And then esophagus and gastric part both can be affected. What is the classification that you have endoscopic grading of corrosive injury?
Zergas
classification.
Zerger's classification, yes. Can one of you, whoever I had just started the questioning with, can answer the types of Zerger? And how does it impact your management? Very important. After what level do you have probability of strictures being formed in a corrosive injury?
2B, more than 2B.
2B.
More than 2B. What is the percentage?
70%.
Question, 70%. Excellent. Okay. And then comes, last but not the least, what is the most common benign cause for gastric outlet obstruction?
PUD.
PUD, sir.
Secondary to most common etiology?
Duodenal.
pylori.
Duodenal.
Pylori.
Okay, secondary to
Helicobacter pylori?
Yes.
Yes, sir.
Don't forget that. So Helicobacter pylori is an important topic. Read about them detailedly.
Okay.
The treatment options. Many times I have even seen gastric outlet obstructed patients started on PPI and anti-H. pylori patients have gotten better because The active inflammation itself will cause duodenal edema and obstruction. Okay, even before we plan an endoscopic dilatation. Okay. Yeah. So Helicobacter pylori, I have deviated a little. Please know the tests. Second, the treatment options. Third, yeah, these two are important topics with respect to Helicobacter pylori. Okay, can we move on to the next topic, that is pancreas? Dr. Manikanta has told disconnection.
Yes, sir.
I don't know whether it's connection problem. Okay, so let me choose a name. Would any Dr. Vamshi, are you with me?
Yes, sir. I'm with you.
Hi. So now I would want to give you a situation of an acute pancreatitis. Okay. Here is the scenario. Ethanol related pancreatitis. He has come in day 3 to us. He is kind of breathless. Okay. He has noted that his relatives have noted that he has slightly altered sensorium. He has tremulousness. How would you want to manage this guy?
Presented on day 3 to us, sir. Managed outside.
He has abdomen pain, severe. You have diagnosed it as pancreatitis. We are managing him in day 3. He is not managed anywhere. He is day 3 of pain abdomen. He has come to you. He has managed himself at home. He has come with breathlessness, so the relatives bought him.
In acute pancreatitis, apart from abdominal pain, since the patient is having breathlessness and altered sensorium, we are thinking in terms of systemic complications of acute pancreatitis, mostly ARDS leading to breathlessness, we have to suspect, and altered sensorium can be due to shock, cerebral edema. I want to go for a chest X-ray first to rule out ARDS, take an ABG to see the PO to FI2 ratio, and start the patient on
After everything, will start him on oxygen.
Yes, sir. I'll start him on oxygen.
So my suggestion is, please, before you go for CT thorax, before you go for diagnosing ARDS, patient is breathless, stabilize him. Okay.
Okay.
Just as a practice, try to tell that first. Whenever, even before the ask question, if possible, let me answer whether stabilizing the patient is the first thing. And then what you are thinking of. Sir, most probably I'm dealing with pancreatitis. As patient is breathless, first I would like to stabilize him and start the patient on oxygen. I would do an ABG to assess the grade of severity of ARDS. If the patient is too breathless despite oxygenation, I would have option of NIV and intubation also. Okay.
Yes. Yes, sir.
See, these are all, you guys are much better than me, right? You guys are physicians who are actually managing these kind of cases bedside. And then comes fluid resuscitation. Okay.
Yes.
Patient is also having encephalopathy. Probably it could be secondary to dehydration. It could be metabolic encephalopathy because of acidosis. Patient could be, he is day 3, probably has stopped alcohol. He could also be in withdrawal because there's also associated tremors. Okay.
Okay.
Yeah. So with these 3 in mind, you then start off the management. Sir, I would like to start IV fluids. What are the IV fluids? How would you like to manage?
I would start with Ringer's lactate, sir, because rather than NS, because of the acidosis that is more paradoxically generated with normal saline. Normally, we use a strategy of 20 ml per kg IV stat followed by 3 ml.
Why did you tell normal saline causes paradoxical acidosis? Like, I didn't understand. Doesn't it normally also cause acidosis?
Yeah. Yes, sir.
No. Be careful with your words.
Okay.
Just tell, sir, RL is a better fluid than NS. I would like to start NS. If the patient is hypotensive, I would like to give bolus of so and so.
Yes.
Otherwise, I would like to give bolus of this followed by maintenance of this and this. Okay.
Yes.
Benefit of patient of other students. Any idea of how you would, what kind of fluids you would want to give?
RL, sir, will give 20 ml per kg stat followed by 3 ml per kg per hour. But the recent waterfall trial, maybe we can go for a restrictive transfusion strategy.
Maybe recently it's been proven that restrictive strategy is better than aggressive strategy. I would like to go for, please go ahead. Tell me.
10 ml per kg stat followed by 1.5 ml per kg per hour.
Okay, 10 followed by 1.5. Okay, that much you tell. And how would you assess the patient?
I would check for the IVT diameter for the I want to check for the urine output for the fluid resuscitation and the hematocrit values too. IVC diameter 1.5 to 2.5 in normal. If it is between 1.5 to 2.5, I would go for the cable index.
Compressibility.
Yes, sir. If it is more than 2.5, I would decrease the infusion rate or
Stop for a while.
stop for a while. Okay.
Okay. Then
Yes.
curly B lines.
Yes, sir.
Other dynamic measures. Leg raise, all those things. Come on, 1, 2, 3, 4, 5.
Leg raise, heart rate variability.
No, whatever. See, medicine, whatever you do as a dynamic part of test, you can also include here. However, there may be some caveats for each of them. Suppose patient has severe ascites also. You know that, leg raise test is not going to be good, isn't it? So there may be caveats. You should know it and then you should talk about it. Okay?
Okay. Yes, sir.
Yeah. So fluid resuscitation, very important. Will you give antibiotics for this patient?
Antibiotics are not recommended, sir, in acute pancreatitis unless.
That's why when examiner asks you, will you give it? You tell, sir, I will not give it. Day 3 of pancreatitis, unlikely patient is septic. I would expect those complications after 2 weeks. Currently, probably he is more looking septic because of the severe inflammation that the patient has rather than infection.
Yes, sir.
What is recommended? Forget it. What you would do, why you are doing it? Because of that particular recommendation.
Yes, sir.
You got it?
Yes, sir.
Excellent. So, see, parallelly, few of guys are chatting, which is good. That is what I also want. Next is, suppose patient has come in, you are giving treatment, ARDS has continued. What is the other complication that you may expect? What are the different scoring system that you use to assess a patient when they present to you with pancreatitis, and how do you prognosticate it?
Sir, Apache score is the best scoring system, sir.
Excellent.
You have Ransom's. You have
any bedside score which is easy to do? Apache, MAN, APG,
scoring. BISAP, sir.
Remember, try to classify your scoring system. Can anybody classify the scoring system based on at admission and then to assess the organ failure and decide on whether to admit or not, and then prognosticate?
Decide on organ failure is modified Marshall's criteria.
Yeah, in pancreatitis, modified Marshall criteria is used to define the organ failure. Okay.
Yes.
So know your classifications of the classifications also. The time frame when you use each of them. Okay. At admission, you use few. For organ failures, once it has started, you use few. Okay.
Yes.
Yeah. Then after 2 weeks, patient still kind of having fever now. Probably you're dealing with septic. What are the antibiotics you think that are useful for him?
Sir, after 2 weeks, maybe we are thinking of a infected cyst, infected pancreatitis.
No. See, you mentioned some words, they will directly get pissed off. At what time will you use the word cyst in a case of pancreatitis? 2 weeks only?
4 weeks. 4 weeks.
Yeah. So it can be just a fluid collection. There can be infected fluid. Okay.
If we are thinking of SIRS, maybe we can start carbapenems, quinolines, and metronidazole for anaerobic coverage.
Excellent. Because these are the ones, not anaerobic cover. These are the ones which will penetrate the pancreas, and there is significant dose that it reaches there.
Yes.
But meropenem or carbapenem, among them also imipenem is better. Okay. And it is not because of their anaerobic action. Please, no word of anaerobes here.
Okay.
What penetrates better and how much do you want to cover? Most of the time it is GI translocation which will cause the infection. So you have to cover the GI organism, which also includes anaerobes. Okay.
Yes, sir.
Excellent. Yeah, that's about acute pancreatitis. Probably not more question than this. It's about management based on timing. When do you want to start the patient on food, nutrition?
As soon as the patient tolerates, sir, probably day 3.
As soon as the patient tolerates. Okay, if it is mild pancreatitis, patient is hungry, you start. If it is moderate to severe, then you give an even earlier by NJ, NG, based on
NG.
what the patient can tolerate. Always better to try orally first. If not tolerating, go for NG. If not tolerating, go for NG. If still not tolerating, go for TPN. Okay,
Okay.
that's it. What is abdomen compartment syndrome? How do you measure it?
By Abvisor instruments, sir. Normal IAP is around 1 to 5.
1 to 5. More than 6 is
Grade 1, grade 2, grade 4.
excellent.
12 to 15, 15 to 20. More than 25 is grade 4.
Yes.
It will cause renal vein compression, sir, abdominal compartment.
Yeah, abdomen compartment syndrome. So, you guys have probably heard all the audios that I have sent. So I'm not going to discuss about each of them in detail. But the tentative question with respect to trials may be waterfall trial. Okay. That was not discussed last year because it just come in that time between last year to this year discussion. Last year we just started the discussion. Yeah. Okay, guys. Yeah. Chronic pancreatitis. Can I have somebody else now for chronic pancreatitis volunteers?
Suhas, sir.
Hi.
Hi, sir.
Okay, hi.
Sir,
So,
sir, in the waterfall trial, the 10 ml per kg bolus is given only when the patient is hypotension, no, sir? Or
yeah,
for all patients we give?
no,
No, not all.
not all. Okay. Now, chronic pancreatitis.
Yes,
What,
sir.
in a case of chronic pancreatitis, what are the 3 complications that you are worried about? Worried, I mean, common complications. When you think of chronic pancreatitis, what are the 3 complications?
Abdominal pain, sir, malabsorption syndromes, that's steatorrhea, and endocrine problems like diabetes mellitus.
Okay. Any specific type of diabetes mellitus?
Type 3C, it's classified as type 3C.
Yeah,
There is both reduction of both insulin and glucagon, so
that's all.
and polypeptides also, all the
Yeah.
pancreatic polypeptides as well.
Exactly. Now that is more defining feature of type 3C diabetes of late. Okay. Initially, we knew that yes, insulin is gone, glucagon is gone, but polypeptide, why? Because of which there is some mechanistic definitions for type 3C pancreatic diabetes. Okay.
Okay, sir.
Okay. Next, PERT. What is the minimum required dose for PERT?
I mean, for complete replacement, you require 90,000 units with every meal. But because there's some residual function of the enzymes present, we start at a lower dose of 30 to 40,000 units per meal, sir. And then slowly titrate up based on the symptoms and tolerance.
Yes. What you have told is perfect. Also know the difference between international units and USP, US Pharmacopoeia units. Okay.
Okay, it's 3 times, I think, sir, the difference.
Yes, it is 3 times. So your 30,000 could be the starting thing, but still because residual and the cost is high, we may start with 10,000 practically, but forget about that. What you have to answer is what you have told. Okay.
Okay, sir.
Okay, excellent. With snacking, you reduce the dose by half.
Okay, sir.
Okay. When it comes to endoscopic management, okay,
Yes, sir.
what are the different types of handling a patient with chronic pancreatitis? Where all you can think of an endoscopic management for the patient apart from medical management?
So if there is constant pain, if it's because of intraductal pressure, either because of a stone or something, then we can use a endoscopic management for the stone retrieval or dilatation of the ducts, sir.
The duct is dilated.
Yeah, I mean, like for
Stricture
retrieval of
management.
stricture. Yes, sir.
Okay. Stone in MPD, preferably in the head, which is symptomatic, you can treat. If it is going till tail, no use.
Yes, sir.
Okay.
Then if there is a collection that is symptomatic, that's causing either duodenal obstruction or gastric obstruction or a CBD obstruction, then we use a step-up approach to try to drain the fluid, or if it's in fact also use a step-up approach to try to drain the fluid. So one of the methods is the endoscopic method to drain it. You can either use a transpapillary or transmural approach, or an endoscopic ultrasound-guided approach to drain these collections.
Okay, good. Management of pressure, then management of fluids. Both has been classified. Excellent. This is what they also want from you. Sometimes pain management, rarely, don't mention it as first. If it doesn't reduce recurrent pain, you can also do something called as
Ganglionic.
what is
Celiac
CPB?
ganglion.
What is the difference between CPB and CPN?
Is this the celiac ganglion block, sir, you're talking about?
Yeah. Celiac plexus block
Plexus
and
block.
celiac plexus neurolysis.
Neurolysis. Yes, sir. Okay.
What will you offer this patient in case of recurrent abdomen pain?
I don't know the differences between the two, sir.
Yeah,
One is I know alcohol guided, one is not ethanol based, but I don't know the differences.
Yeah, the difference is neurolysis is you lyse the neurons by use of alcohol, and that is done for pancreas carcinoma patients. Okay, this is a benign condition, so you don't do that. You just give a block where you have a
Okay.
mixture of bupivacaine,
Okay.
which is predominant long-acting anesthetic agent. Okay,
Yes.
and with some amount of steroids also.
Okay.
Okay, so that's about chronic pancreatitis. You know the dose, you know their side effects. Any side effects of PERT that you are aware of?
No, sir, I can't remember. No, I've read it, but I can't remember.
Yeah. Anybody else?
Fibrosing colonopathy.
Fibrosing colonopathy. What is it? Where does it occur? What is the primary scenario where it can occur?
There is a, if you give more amount of PERT, more than high doses of PERT.
Yeah. Initial days, what was done as in cystic fibrosis, they were giving a huge amount of PERT, where significant number of patients used to get bowel obstruction, and then it was decided to reduce the dose. Okay, currently with the doses that we are using, we may not get this complication, but this is one of the complications that you guys might have to know about. Okay.
Does disconnected pancreatic duct syndrome and say pseudaneurysm come under complications of acute necrotic, or can we even consider as chronic pancreatic complications, sir?
It can be usually most of the time they are because of acute severe pancreatitis.
Okay, so in this
Disconnected
case,
pancreatic syndrome.
don't have to really tell about them.
No. Chronic pancreatitis also can get infected with the pancreatic fluid. But these are what we generally see as acute severe pancreatitis. As a sequelae, you can also get a disconnected pancreatic duct syndrome.
Okay.
Okay. Anything else? Any doubts? Because this topic is again important, and then
So
it's
the
not.
tension and Miser trial are based on this only, sir. I mean, for this only, sir, for the endoscopic approach of the fluid drainage.
Yeah. Now, we are not going to drain a patient just because the patient is acute severe pancreatitis and there is fluid.
Yes.
After the second week, patient still deteriorates. We always wait. Okay. Still the fluid collection is symptomatic. That is when we decide about to go ahead with percutaneous or endoscopic, then followed by surgical if endoscopic is not feasible. Okay.
Okay.
Some rare types, there's a specific type where you may get just disconnected duct syndrome causing pancreatic ascites, where putting just a PD and reducing the pressure itself is helpful.
Okay.
There is specific types. It's not infected. Necrosectomy word is used when you have an infected necrosum or collection. So bridging plastic stent used for DPDS. Yes, if you're able to bridge well, but practically many times we may not be able to bridge both the sides. So that time even EUS guided stent putting, when you put a stent there also might be helpful. Okay, if you're not able to reach the distal end. Yes. Practically, for all practical purpose, acute necrotizing severe pancreatitis usually leads to these kind of complications. That doesn't mean it will not be seen in other form of pancreatitis. What you see commonly is what we should discuss about. Okay. Yeah.
Yes.
Next is extrahepatic biliary obstruction. Now, why I didn't mention specifically few topics like pancreatic cancer, gallbladder cancer, ampullary malignancy, cholangiocarcinoma is you have to know all these four topics in under one heading called as extrahepatic biliary obstruction. Okay. All of you would have heard the discussion, but anyway, Dr. Sohail, are you with me? What is the most common type of extrahepatic biliary obstruction caused because of?
Sir, most common cause of extrahepatic biliary obstruction.
Yeah.
Sir, it is GB carcinoma, sir.
GB carcinoma. Are you sure?
Yes, sir.
Okay, with respect to prevalence in our country.
Prevalence.
India, it
In
is
northern-
mentioned as gallbladder
I'll give you a
carcinoma.
simple question. Whenever patient presents with obstruction or jaundice, first think of obstructive and then also think of intrahepatic causes. Okay. The
Yes,
points which favor towards extrahepatic biliary obstruction are, how do you
Previous.
differentiate between extrahepatic and intrahepatic? That is very important practically.
On history, sir.
Yeah, history and investigation. You have to classify and tell me. You should not ask questions to me. Intrahepatic.
Sir, progressive jaundice.
No, that's
History, previous history of surgery, sir.
Jaundice.
Per biopsy.
Painless jaundice is suggestive of extrahepatic malignancy, periampullary carcinoma or cholangiocarcinoma.
okay. I'll tell you one thing. There is some confusion.
Biliary surgery, any gallstones or features of cholangitis. I think they more point towards extrahepatic.
Extra points towards extrahepatic are pain abdomen, presence of fever, presence of lump, presence of any previous biliary manipulation in the form of ERCP, or any procedures in the past, all in the upper abdomen suggest of an extrahepatic biliary obstruction. Presence of a prodrome, presence of high risk behavior like previous transfusion, sexual promiscuity, and history of CAM intake. Okay.
Yes.
These are few things which suggest towards this. Presence of jaundice pruritus will not tell you towards which of these causes. Okay, they are not specific. Progressive, intermittent, it doesn't tell you anything. Okay. Then when you can classify and tell them apart from history, even on investigations, we can get some idea. Like say patient's PT-INR is D-range and it reverses with vitamin K. If it reverses, you are dealing with an extrahepatic obstruction. If not, you're probably dealing with intrahepatic obstruction. Things like this, minute differences. Okay. Then comes extrahepatic biliary obstruction can in itself be benign and malignant causes. Okay. Classify benign causes for extrahepatic biliary obstruction. Just one.
Autoimmune pancreatitis, sir.
Intraluminal causes and compression from external external sources.
Classify. Luminal, mural, extramural. Okay. Luminal causes could be stones, most common cause.
Yes, sir.
It can be
Parasites.
blood, hemophilia. It can be worms.
Yes,
Can be
sir.
one.
Anything. Nah. Then comes mural cause. Mural cause can be single stricture, like your answer, which is post-cholecystectomy, or it can be multiple strictures.
Yes.
Multiple strictures can secondarily be primary sclerosing cholangitis or secondary sclerosing cholangitis. Single strictures can also be anastomotic strictures.
Yes.
Okay. Extrinsic compression. Extrinsic compression can be at different levels. It can be an ampullary malignancy. It can be pancreatic malignancy. It can be a Merices syndrome. It can be portal lymph node having some pathology which is compressing the CBD. Okay. I'm just going in one go. So when you classify, you see how many causes we were able to tell you.
Yes.
Yeah. So when suddenly they ask a question, think whether you can classify. Okay. Again, I've repeated this again. Yeah. Next comes malignant cause. So far, we have discussed benign causes. Next come to malignant causes. What you have already mentioned the 4 malignant causes. I will repeat them again. Ampullary malignancy, pancreatic malignancy, cholangiocarcinoma, gallbladder malignancy with locally advanced. Among these 4, which is most common?
Ampullary malignancy.
No, that means you have not read this one. The most common malignancy is pancreatic malignancy. Okay. The carcinoma head of pancreas is so common that it even beats some papers tell, of course, gallbladder malignancy can also be quite common, but most of the patients concur to pancreatic cancer. Okay. Why I'm telling you this again is when they ask you what are the probable causes, you should be able to tell a pancreatic malignancy above cholangiocarcinoma and ampullary cancer. Okay, there is a doubt between GB and this, but I would still prefer pancreatic malignancy, head of pancreas being more common. Okay.
Sir, in that paper by Dr. Vivek Saraswat, sir, he's mentioned that in North India,
Gallbladder.
it's gallbladder carcinoma. So,
Yeah.
any specifically should we mention it or not necessary? Because other books, everything say pancreatic head of carcinoma, right?
I agree with you. See, one single study cannot become everything, right? So most of the study, see, that's why I'm telling first two causes you can always be doubtful. Pancreatic cancer, according to many studies, but few studies like what you have mentioned, Juniper et al, it was published there. What is rarely seen? Yeah, correct. When you compare entire India, carcinoma pancreas will come up because gallbladder malignancy isn't that common. Okay. Maybe in that set of country they did the study, probably in Lucknow, is what they got was gallbladder. Okay.
Okay, sir.
Yeah. So what you have to know is there's a tight competition between GB cancer and pancreatic cancer, but pancreatic cancer may represent the entire country. Maybe in North, GB is much more also.
In the North, specifically the paper, GB cancer.
Yeah. Okay. Yeah. Now I want to tell you some clues to tell you what is the kind of malignancy you are dealing with. Okay. Everybody has jaundice. They may have pain a little bit. Okay. But what is a differentiating factor towards each of these malignancies? What you should know. Suppose patient comes to you with painless progressive jaundice. What is the cause that you are thinking about?
Periampullary carcinoma.
No.
Pancreatic.
Head of pancreas.
Among these, I will tell head of pancreas is the first. Second will be cholangiocarcinoma. Okay. Cholangiocarcinoma will present with painless progressive jaundice. Even a pancreatic malignancy can present with painless progressive jaundice. Okay. Patient has pain, right upper quadrant pain, quite severe, and jaundice. What are you thinking of?
CAG.
CAGB.
Ampullary carcinoma.
No. Wait. Next, patient has intermittent jaundice.
Ampullary.
Patient has
Of John.
intermittent stools, which are
Silver
like
color.
kind of melena or silvery.
Yeah.
Patient has low HB. Okay. These are the patients where you will think of ampullary malignancy. Got it?
Yes, sir.
Yeah. Why does it happen? Why is it intermittent in nature?
Slogging of tumor.
Crystal CBD blockers.
The sloughing of tumor, because it can overgrow its own blood supply intermittently again and again, causes intermittent obstruction.
Okay.
Leading to intermittent jaundice. The same sloughing can also cause blood loss and sometimes silvery stools also.
Sir, can you repeat for a scenario for carcinoma gallbladder?
Carcinoma gallbladder presents with significant right upper abdomen pain along with the jaundice. Pain is the characteristic feature. When it comes to pancreatic cancer, almost 50% of patients can have pain, 50% it can be painless. Okay?
Okay, sir. Thank you, sir.
Again, this 50% can be still 30% according to few studies. I'm trying to just make it simpler for you guys. Am I clear with extrahepatic biliary obstruction and the common malignancies?
Yes, sir.
Yes, this is what take-home message is. When based on the subtle other causes, you should be able to tell what are the most, see, 4 differentials you will keep, but what will you keep up and what will you keep bottom is most important.
Yes, sir.
Yeah. So they will tell, otherwise they will give classic history. Patient with jaundice, pain, progressive jaundice, pain is present, patient has steatorrhea, patient has new onset diabetes, patient is a chronic smoker. If they tell all of it, it becomes easy. What is it?
Head of pancreas.
Head of pancreas.
Exactly. If they give all these 5 points, it is obvious, but that is not their purpose, right? They are going to give you only 2-3 points and they'll extract information from you. Next is hepatomegaly, splenomegaly, and mass per abdomen. Why I have included all this topic into similar heading is because it is more of a discussion topic rather than a clinical examination. They may test, of course, how are you going to measure spleen, how are you going to see clinically hepatomegaly, splenomegaly, and they might ask you, if you get a mass in right lower abdomen, left lower abdomen, what are you thinking of? Okay, these are the things they may ask you. For this specific question, the best book will be Das. Go through the different quadrants of abdomen and what are the different DDs that you can get at different quadrants. That should be enough for this. Okay.
Okay, sir.
Yeah. Splenomegaly, hepatomegaly, I need not tell you anything. But anyway, let's have a very small discussion for next 5 minutes. What are the causes of splenomegaly? Dr. Rohit?
Yes, sir.
Hi. Simple question.
Yes.
Splenomegaly, how do you want to classify? Of course, there may be mild. Yeah.
Splenomegaly can be generally classified as mild, moderate, and severe. The grading is based on the centimeter. Up to 4 centimeters mild, or 4 to 8 centimeters moderate, more than 8 centimeters classic splenomegaly.
Excellent.
Clinically also we can classify as mild, moderate, severe. The spleen which is extending from left upper quadrant to midway between umbilicus is mild, and the spleen which is extending up to umbilicus is moderate, and the spleen which is extending beyond umbilicus is classic splenomegaly.
Excellent.
The pathology or causes of mild splenomegaly includes generally infections, inflammations, inflammatory conditions. Then moderate splenomegaly includes liver disease, thalassemia. The massive splenomegaly mostly includes malignancies, CML, leukemia. Like that.
Okay. You have not put our important cause for gastroenterology. I know you are a good physician, but some of our causes, cirrhosis, NCIPF, EHPVO. Okay, because these are few causes for kind of even significant splenomegaly. Okay.
Yes.
Okay. So here, please go through difference between extrahepatic portal vein obstruction and NCIPF. Can anybody tell differences? At least one or two?
Extrahepatic EHPO is more of first order branches, sir, and second or third order branches are more involved in NCPF.
Excellent. This is the best definition possible. Okay. You cannot demonstrate clinically that there is a block. Portal vein will look completely normal on imaging, except that it may be dilated, say maybe reversal of flow. Okay. But the parenchyma of liver is completely okay in both these conditions. The block, level of block is important. Okay. Presentation wise. Definition you have told.
History of umbilical cord sepsis.
First age. Yes.
Yes, sir. EHPVO.
EHPO is younger.
Younger, yeah.
NCIPF is little later.
The adolescent age group.
Adolescent age group is EHPVO. Something like second decade, third decade will be NCIPF. Okay.
Yes, sir.
History of umbilical cord sepsis is usually extrahepatic.
Okay. Yes, sir.
Yes. Spleen is significantly big in both of them. Recurrent history of GA bleed is the first symptomatology in either of them. They do not decompensate usually because it is a pre-sinusoidal cause, but once a pre-sinusoidal cause becomes sinusoidal, they can still start presenting with ascites also. Are you guys with me?
Yes, sir.
Yeah. Here they will ask you what is the definition of portal hypertension? What are the ways to measure it?
HVPG more than 5. HVPG more than 5, sir.
Yeah. HVPG more than 5. What is clinically significant portal hypertension beyond what?
More than 12. 10, sir. More than 12 is a risk of variceal bleeding.
Excellent. So know these
More than
numbers
10.
very well. More, no 5, 10, 12. Okay, these three numbers should be known. Next comes, now let's come to liver per se. Okay. Hepatitis. They will ask you clinical scenarios of hepatitis. It could be autoimmune, it could be hepatitis B, it could be hepatitis C, it could be drug induced, it could be Wilson's disease, anything. Okay. What is the HVPG on EHPVO is a question by one of you guys. Obviously, it's going to be normal. No, it is pre-hepatic. Yeah, excellent. So I'm not telling that is used to differentiate. Their imaging itself can differentiate there in those conditions. Sometimes you might have to do HVPG. Definition wise, it may go into that. Okay, excellent. So hepatitis, it's a theory topic. You might just get questions like patient had prodrome, has jaundice. What are you thinking of? If you're thinking of hepatitis A or hepatitis E, what is the test you want to do? Hepatitis B, hepatitis C, what is the test you want to do? Now the natural history of all of them, which has been discussed quite well before. Read them if you don't know. Then comes other etiologies like drug-induced, autoimmune causes, which has to also be known with respect to hepatitis. Then special scenarios can be asked with respect to management, like in pregnancy, how would you manage a special form of acute liver failure that can occur in pregnancy specific. So those questions can be asked here. Second, Budd-Chiari syndrome. What is Budd-Chiari syndrome? Let's ask one of you guys, because it was asked by each of them had been asked in last year. So I'm just continuing them. Dr. Kashim is with us.
Yes, sir.
Hi.
Hi, sir.
Hi. So what do you think is Budd-Chiari syndrome, Dr. Kashim?
The Budd-Chiari syndrome is the obstruction of the outflow tract of the liver, sir. Specifically, either the hepatic veins or the junction of hepatic vein at the IVC, sir.
Excellent. Now, what are the two commonest form of presentation of these kind of patients?
One is acute onset ascites, sir.
Excellent. One is acute, one is chronic.
Second one is chronic.
Excellent. So if a patient has acute Budd-Chiari syndrome, what are you thinking about?
First, I'd like to ask the age of the patient, sir. If he or she is a young to middle aged, I'd like to think about the thrombophilia, inherited thrombophilia disorder.
So know about how to manage or how to evaluate thrombophilia. Okay. JAK2 most common. Any new molecule?
Calreticulin.
Calreticulin. Yes. Did I pronounce it right? Calreticulin.
Retinine.
Calreticulin is what I thought. Okay. Anyway, guys, go through those new molecules have come. Calretin mutation. Okay. Yeah. See, somebody is with me. Calreticulin mutation. Okay. Yes. I may be wrong though. Okay. Okay. Suppose a patient has come with acute ascites. You have diagnosed Budd-Chiari syndrome. And what is the next line of management?
Anticoagulation is the mainstay of treatment.
Anticoagulation is the mainstay of treatment, but anything else you can do?
First, you have to work up the investigation, sir.
Yeah. So first is whenever they are expecting investigations, tell like routine investigations followed by special investigations. Okay.
Okay.
Routine investigations, obviously you are going to see a CBC. You will know HB may be high, platelets may be high, patient has splenomegaly, but still platelets are high. Then you are thinking about
myeloproliferative neoplasm.
Myeloproliferative neoplasms.
Yes. And a special test to know what is a specific diagnosis. You might even end up doing bone marrow also. Okay.
Okay.
So one is that line of investigations you should be able to talk. Second, there is ascites. You would want to know whether it is high SAG, high protein ascites. What are you expecting in this case?
Early BC.
High SAG, high protein, and
the early
BC.
High SAG, low protein, sir. Later it becomes high SAG.
Reverse.
Initially high SAG protein, and later it becomes, because of scarring, it becomes high SAG, low protein.
Yeah, simple.
Yes.
Acute Budd-Chiari, the pressure is high. Okay, so high protein and high SAG. Okay, yes. As it goes towards cirrhosis or chronicity, it will become like cirrhosis. What is it going to change it as? Total hypertension is there, so high SAG, and scarring is there, so or fibrosis is there because of its
low protein.
So high SAG, low protein. Okay, see, there is interventional radiologist's role here. Okay, what you guys have to know is they can do plasty if there is. They can put a stent also there. Okay.
Okay.
Yeah, these are things you should know. So interventional radiologists do have a role in management of these patients, followed by, of course, anticoagulation for significant amount of time. That again depends whether it is, mostly we would give it lifelong, but then depends upon the etiology also that we are getting. Next is chronic liver disease. It can be from fatty liver, or it can be steatohepatitis, or it can be cirrhosis. Know each of them well. Okay, the etiology could be non-alcoholic or it could be ethanolic. Recently, there is a nomenclature change that is suggested for NAFLD, which is MASLD.
Acid, yes, sir.
Okay, know about them. Because still it is controversial thing, they may not dwell too much into controversies there. Okay, yeah. Next important thing is complications in cirrhosis. You can have bleed, you can have ascites and SBP, you can have HRS. These you can have portopulmonary hypertension, you can have hepatorenal syndrome, you can have hepatic encephalopathy, cardiac, you can have cirrhotic cardiomyopathy. Okay, these are the complications that you should know about. Of course, HCC is in itself a separate topic. So HCC also very important. You should add on here actually. Okay, guys, are you with me?
Yes, sir.
Yeah. Now, today we cannot discuss about each of them. What I want you to know is management of SAG. The investigation that is SAG based should be known well for ascites. I have repeated in different classes. If you want it, I can separately create an audio and just push it on today in the WhatsApp. Second, management of HRS. This is asked, so I want one of you guys to tell me. Dr. Manikanta, are you with me? Can you just tell me the management of HRS, diagnosis and then management?
Yes, sir. I'm with you, sir. Diagnosis. First, we have to satisfy the whether it is volume responsive or volume non-responsive AKI, sir. That is a criteria for HRS. The patient should have ascites
Okay.
with cirrhosis or acute liver failure, and the patient should have AKI definition as per the KDIGO guidelines only. Next, there should be no use of nephrotoxic agents or no use of nephrotoxic agent, and there should be no intrinsic renal kidney disease, and there should be no response even after stoppage of diuretics and giving albumin infusion for 2 days. If it is there, we call it as a HRS AKI. For the HRS AKI, we can start vasoconstrictors such as terlipressin plus albumin infusion should be given.
Yeah.
Terlipressin, the dose is 2 mg per day, can be maximum up to 12 mg.
Okay.
Alternative to terlipressin, if it's not available, we can go for midodrine plus octreotide plus albumin, or noradrenaline plus albumin can be given.
Okay, excellent. Know their doses here, because in interview, at least for important management, all this GI bleed or this terlipressin dosages, midodrine dose, octreotide dose, it should come in your fingertips. If you have a doubt, go through the table again for HRS AKI. Okay, very important. Then comes bleed, difference between portopulmonary hypertension and hepatopulmonary syndrome. Okay, both are pathophysiologically entirely different. One is completely vasoconstrictive hyperproliferative condition. One is a vasodilatory condition. Okay, know their numbers. Definition wise, the numbers is important. Okay, yeah, PAP more than 20. Excellent. Okay, then how about liver transplantation? Again, a very important topic. You should know the absolute indications, relative indications, common indications, contraindications. Okay, this much, and some complications and their management. This much you should have an idea. Okay, then interventional radiology procedures will come here. TACE, TIPS, at least these two procedures. Rarely they may even test. A patient has presented to you with cholangitis. How are you going to manage? Okay, patient has come to you with perforation. How are you going to manage? Again, this is a topic I wanted to include as a 11th topic. Complications. And yeah, so any complication, you should be good at management. Okay, like say example, cholangitis. Patient has come with cholangitis. What is your management? Stabilization of the patient followed by biliary drainage. Biliary drainage can be done based on patient status. If is hemodynamically unstable, consider PTBD. If it is stable, you may consider doing an ERCP and stenting. Okay. If there is perforation, what classification do you use for classifying ERCP related perforation?
Staff.
Stab first. Okay.
Staff.
Then Schoffer's, just be careful, guys. It's Stafford's classification, because they will ask you more questions that have recently asked you in your theory exams. Okay. Know how to manage them. Then Because perforation and cholangitis are two significant complications which, as a resident and as a gastroenterologist, you should know how to manage. Okay.
Yes, sir.
Next comes hepatocellular carcinoma. In hepatocellular carcinoma, again, no Milan's criteria, recent BCLC classification. Note it down, recent modified BCLC classification. Because here you have Strasbourg classification is for stricture. What perforation classification is for Stapfers. Yeah, bile duct injury also like strictures only. It is again this classification. Okay, correct. HCC, I have told you to remember two things. Again, the first line management has changed. What is the first line systemic therapy for HCC?
Tezolizumab, bevacizumab.
Yeah, it is a systemic therapy with those. Know their trials well. Okay, what is I Am Brave trial?
Tezolizumab and
Bevacizumab.
bevacizumab.
What is Everest trial? You would want to read about it? No, sorafenib is all gone here. It's not first line anymore. Okay, somehow your name is coming as 1+. I would like to know what's your name. Sorry for that. You've been very active in most of my classes, but then it's very difficult for me to call you as 1+. Dr. Sejal. Okay, thank you.
Sir, can you come again for first line of HCC?
First line of HCC was initially, according to previous BCLC, it was sorafenib. Okay. Now, in the modified BCLC, based on recent trials like I Am Brave trial, you have atezolizumab with bevacizumab as the first line management. Okay.
Yes, sir.
Apart from it, there are other studies which recently new drugs. See, these are all like, drugs which are difficult for me also to pronounce. They are immune checkpoint inhibitor like durvalumab. Have you heard of this?
Yes, sir.
Yeah, that particular drug in combination has been tried in a trial, and even it can be the first line drug. Okay. Yeah. If they do not work, in Harrison also it's given back. You just go through one slide on BCLC classification, you will get that what to be given as first line, second line, and third line. And if don't work anywhere, if they don't come anywhere, you're going to put the patient on trial. Okay. No Milan's criteria, no extended criteria like
University of California San Francisco criteria.
Yes, excellent. UCSF criteria. Okay. These two criteria are important. And then, yeah, HCC is covered. Then imaging wise, please know how to identify HCC. Okay.
Yes, sir.
Very important. Are you guys with me?
Yes, sir.
Yeah. Next comes chronic diarrhea. Now, chronic diarrhea, very important question. Know to classify diarrheas. Okay. And then how to evaluate diarrhea and malabsorption and malnutrition. Okay. Yeah. They may ask you, how do you evaluate an inflammatory diarrhea? How do you evaluate an osmotic diarrhea? How do you evaluate steatorrhea? What is protein losing enteropathy? All are slightly related, but these are the questions they may be asking. In this malabsorption, don't forget two important conditions in a differentials. This is celiac enteropathy. Second is tropical sprue. Okay. So these two things should be remembered here. Apart from that, one of the differentials can also be inflammatory bowel disease, Crohn's disease. Okay. In IBD, Crohn's and ulcerative colitis, they may just try to explain to you or try to see whether you have any knowledge in management of steroids, management of azathioprine, management of 6-mercaptopurine, and the newer biologicals and small molecules. How to assess a patient's severity when the patient comes. Okay, these are the things which will be tested. They may ask sometimes management of toxic megacolon. Okay, in a case of ulcerative colitis. Now, these are specific ways of answering them. Okay. Suppose a patient comes with severe ulcerative colitis. How do you know it is severe? What classification will you use clinically?
True Lovett criteria.
Simple classification, True Lovett criteria. Okay. Then you might do an endoscopy. If you do an endoscopy and based on it, how will you tell it is severe? Any classifications you should be able to tell.
UCIS or Mayo.
UCEI, especially because it was asked in your exam also. Apart from that, there is Mayo's criteria, Montreal's classification. If you know, you can tell them, but know at least UCIES. Okay.
Yes.
And then know the drugs and their respective trials if you can't remember. Otherwise, no need. If you have already read, it is well and good. Okay.
Yes.
Next comes constipation. Evaluation of constipation can be, how do you classify? It can be primary, secondary, it can be functional. Okay. I mean, secondary is where you have a cause like mechanical or systemic. Functional is where it could be a slow transit constipation, it could be a normal transit constipation, or a defecatory disorder. Okay. Sometimes pain, constipation with pain becomes IBS also, irritable bowel syndrome, abdomen pain. Okay. Here, they may give you alarm features like rectal bleed, how to manage lower GI bleed, how to manage a case of carcinoma colon. These 3 questions may be asked. Are you guys with me?
Yes, sir.
Yeah. Suppose example is, how do you evaluate a patient with defecatory constipation? Can anybody answer? Dr.
Anorectal manometry.
Yeah. How will you excellent. Any other added test to you apart
Balloon
from manometry?
Balloon expulsion test.
Scintigraphy.
Defecography, balloon expulsion test, and anorectal manometry. There are 3 tests for rectal evacuation disorder we do, sir.
Superb, excellent. But just like stabilizing a patient for different conditions, here please tell per rectal examination because they are very important. Okay. 2 things when you put, one perianal examination and then per rectal examination. Once you do it, you look for basal tone and squeeze pressure. Okay, please don't forget it. I have seen students forget this and directly tell anorectal manometry. Then they will ask you anything else. You will be like defecography. Anything else? They are expecting something very simpler. Okay. I'm just helping you answer them. Just think something, don't answer directly. If you know an answer directly, no, just think little bit should I answer something else simpler and more commoner, then come to this answer. Okay.
Okay, sir.
Because a good digital examination is a test which is even better than manometry when it comes to defecatory disorder. You can have a prolapse when you ask them to push. The entire thing may come out, isn't it?
Yes.
Yeah. So clinical examination becomes important. That's why I've asked that specific question. And then comes, guys, please go through your thesis book once.
Sir,
They
what
may
is the
statistics.
use for rectal examination? Is it SIMS or any other method? Left lateral position we use.
Your voice broke. I heard only left lateral from your voice, doctor.
SIMS position is preferred or left lateral position is preferred, sir?
What is SIMS position?
Right, patient lies on the right side with right leg is being the straight and left leg is bent. I mean, hip and knee are flexed.
Okay, I have not heard of this SIMS position, but did you come through this somewhere?
Actually, I was going through it, sir. Actually, some mention as a SIMS as a right lateral position with the right leg being the straight and left leg is knee flexed and hip flexed, sir. And the other one is left lateral position they're given, sir. They have mentioned something else number like I forgot the name, sir.
Okay. Before I tell something,
yeah, sir.
This one question, I myself don't know what is SIMS position. I have not heard of it also. Maybe it's a very common thing which I have not concentrated in our practice. Maybe, see, what we generally do is left lateral position, okay? And right leg, hip is semi-flexed and the knee is all flexed, okay? And then separate the buttocks and then gloved hand, jelly, perianal examination, followed by insertion 180 degrees on either sides, completely assess what's happening around, and then check also have an idea about the basal tone and then the squeeze pressure. Now this in steps if you're able to answer, and then once you remove the finger, if you're able to see any blood stained stools. These are the different. Yes. Okay, this much they may ask you, but position, I think remind in the group. I will also see towards today only and we'll put, because surgery book I have not read for this. Sorry. Which book is good for this? There's an article, good article on constipation by ISG, where the author is
Ghoshal.
Dr. UC Ghoshal. Please go. They have given all of it in detail, but I don't know if they have mentioned SIMS position. Okay.
Left lateral they have mentioned, sir. UC Ghoshal.
Yeah, left lateral I'm sure of, but something Sims position I don't know. We'll see it. Let's have an idea. If they ask us, is there any other position, we should be able to answer, right? Surprisingly, all of you will answer that. Okay. Okay. Okay, guys. Almost all the approaches has been discussed, which was what was really important from discussion perspective. Any other doubts so far? No, most of the questions, 99% has been covered now. At least 95%. Some rare questions can come up. Please go through the audios which I have just put up in the group. Okay. Then, yeah, your routine revision notes. That should be sufficient at this point of time.
The spotters tomorrow, sir.
Yeah, I'm planning to I'll just give a call to the management and see if I can continue and finish it off today. Okay. I
Yes.
don't want to keep anything last minute. The time given to me was actually tomorrow evening, but then it was just not feasible for tomorrow. Just
Sir,
give me-
if you want continue, you can continue, sir.
Okay, Saidulu, shall I continue? You told only till 9 o'clock.
Yeah, I have adjusted some other things, sir.
Thank you. Thanks a lot. Thank you.
Okay.
Okay, guys. So yes, here is so we have approach was most important. So my idea was to complete the approach part. So guys, statistics wise, also some things has to be known. I'll just come up in the slides later. Shall we go and see some basic things how to manage and how to answer the spotters? Because spotters have been discussing every year for the last 2 to 2.5 to 3 years.
Yes, sir.
Initial phase, there were spotters. Suddenly, spotters disappeared, but they were asked in different form. They will give you clinical scenarios. In between, they used to put these spotters and ask, how will you manage this? In this patient, CBC is like this. Endoscopy picture was like this. Then we did this IR procedure. Then this was the CT scan of this patient. That way also it will help you. Okay.
Yes.
So when you present a history, this is more important when you have to examine a patient and present a case. But at this point of time, sometimes they may ask you with respect to history, few questions when they ask what is important and what is not important. Like suppose when they tell a patient is ethanolic and he has significant alcohol consumption, and they will mention to you what the units of significance. So know them. Second, in the history, when they're examining for a patient, they may show you pedigree chart and tell this is the story. Is it autosomal dominant? Is it autosomal recessive? These things also, please concentrate. Okay. Third is when you have to tell what students sometimes forget in few indication is cutaneous markers of internal malignancies, especially in general examination. Sometimes you guys may forget. Look for this, especially if you are examining the patient, but at your scenario, it may not be important. Okay. So spotters wise, these have been asked last year. So just let's go through them again. One is case-based scenarios like post-ERCP perforation. Incidentally detected HPS-AG, what will you do was directly asked. Then an approach to a patient probably who has BCS, like 3-month-old postpartum ascites, how do you approach? Like whatever we have discussed, just like spotters also they've asked. Second, some instruments have been asked like CRE dilatation, that is controlled radial expansion. LAMS. LAMS is a new form of self-expanding metal stent, which is lumen opposing. The lumen opposing metal stent is called LAMS. Third is Ovesco's clips. So go through these pictures and try to know them. Third, histopathology of important slides have been asked. Are you guys with me? I'm getting some disturbance.
Yes, sir.
Yeah, histopathology of important diagnoses have been asked. Then comes imaging. Imaging triple phase CT to identify a HCC is really important. Guys, if some of you have your thing unmute, please mute so that there's no disturbance. Yes, all of you mute. Excellent. Thank you, guys. Then CT for identification of chronic pancreatitis. They had also put 4 pictures of barium swallow. Fibroscan recently has been asked. Doppler for Budd-Chiari syndrome has been shown. Okay, these are the things which you guys can go through. Then thromboelastography has been added recently. So I've just put up in this discussion itself. They will show you different values and tell how are you going to manage. There are different subsets when you're evaluating a thromboelastography. One is R factor, alpha, and kappa, and then comes the mean lysis period, and there are different categories based on which is abnormal. You might have to give different blood products like FFP, cryo, platelets, thrombolytic agents. Okay, so go through these things. Then endoscopic pictures have been asked, right from esophagus, right from esophageal esophagitis, esophageal candidiasis, corrosive esophagitis, gastric malignancies, colonic malignancies, cholangioscopic pictures, capsule endoscopy pictures. These are the different kind of pictures they may ask you. Classifications have been tested. Newer drugs, if any, recently added on, please go through them. We have recently put up in the group about some of the new drugs. So FDA approved ones, you can go through them. Few important trials wise, nutrition, there are IBD, NASH related drugs. There are trial names which has been asked before. If you guys can know, please know them. Statistics wise, they can put a picture, simple Kaplan-Meier curve, RCT based. Recent questions I want to just add on here. Till now they were asking about RCTs. Now know about meta-analysis. Meta-analysis, you have some network meta-analysis. Then there is something called a mesh graph. Then you can have something called as superiority index, I2 heterogeneity index. So these are few terminologies with respect to meta-analysis which they may test. So far the questions were on test of significance. Students started answering many of these questions, right? So they next went into RCT. What is pragmatic trial? What is the difference between efficacy and effectiveness? Okay, people were answering this. Now the question is on meta-analysis. So they are putting forest plot. Forest plot again is a question. Then funnel plot. If you ask me, teach this, very difficult. If you really want to go through them and try to understand a little bit of it, just Google it and try to have a basic idea about these things. Okay. Yeah. Next is, few students have been asked about their thesis and that related statistics. So go through that also. These are points which will add on. When you have to summarize a case, especially they will tell you a story, you have to summarize and tell them. Always tell the answer in terms of syndromic diagnosis, where you can tell the differentials and then tell the etiology, complication, comorbidity, and performance status of a patient. Now, this is important, really important when you are presenting a case. But currently, have this to just summarize a case, because you're not going to examine a patient, but you have to have an idea while presenting. Sir, currently patient has portal hypertension. I would like to think of intrahepatic portal hypertension. Etiology could be viral hepatitis. Current complication is ascites. His existing complication has been diabetes and CVA. Current performance status is so and so. Like that, if you're able to tell, it's more impressive and it presents on a platter for them. Okay. Now is the actual discussion, that is spotters. Thank you for I thank the management for giving time now. So I have discussed some basic pictures. So how you prepare for spotter is go through Schlesinger page by page, the pictures. That's all you should do. Now it's a test. Now all of you can unmute yourself and just start answering what you are seeing. Okay. So yes, guys. So what is this picture? This is an electron micrography picture of some
M cell.
Huh?
Microfold cell.
Yes, it is M cells. Now I was wondering initial stage, where is the cell? Okay. So you see the C-shaped cell here. Something like this. This is the cell. It's a M cell or microfold cell where the antigen actually presents, and this is presenting in turn to the macrophage. Okay. So it is M cell. This just tells you how good you have checked through your Schlesinger. That is why I've directly gone to something in depth. Next is, what is this instrument?
Can you just tell about 2-3 points with each of these spotters, in case like what questions they may ask?
What is the function of M cell?
Antigen present.
Antigen presenting. So what it does is it kind of
Processes antigen.
processes the antigen and presents it to the cell beneath it. It is significantly present in the terminal ileal cells or Peyer's patch. Okay.
Yes, sir.
Okay.
Yeah. Now, this is just to give you an idea. What is this, guys?
Like tube.
Excellent. This is a
Peg tube.
simple peg tube, but normally what is the thing is, for normal peg tube, we insert it endoscopically. Okay. They might not ask you the importance of or how we are going to exactly do it, but what really is important is to identify this. Okay, so what will happen is endoscopically we would have inserted this from internally and pulled it externally. Okay, and the skin lies at this level. So what this projected thing is what you would be able to see. Then they fill in this particular balloon. So this is a kind of replacement balloon. Usually when we put the first peg tube, no, there it will be just a plastic like this. There won't be a balloon. Okay. This can be easily plugged and removed. After that, what we put is called replacement tube. This is a peg replacement tube because there's a balloon at the tip. Okay. Are you guys with me?
Yes, yes, sir.
Excellent. So this is not Minnesota tube, Sejal. Minnesota tube, I will come back again. That is like a Sengstaken Blackmore tube. Okay. Yeah, this tube you have never seen. I agree. Obviously, I will not expect it, but they may show it to you. It is nothing but peg tube. Okay. Peg replacement tube. Okay. So peg tube will have same structure, but it will have one more plastic thing here, and this balloon won't be there. Okay. That is the first time what we put peg tube. We'll just have a plastic here. Now what this is having is, it's a replacement tube where once a peg tube is placed, you don't do an endoscopic procedure completely for the patient. You just pluck and remove it and try to insert this and then dilate. It's like Foley's tube. Okay, like Foley, same mechanism. You put it inside and then dilate the balloon. The balloon will in turn fix it across the skin. Are you guys with me now? I need a feedback.
Yes, sir.
Yes, sir.
This is a complication of peg placement. See, here there is no balloon. It is a plastic thing. So what has actually happened? The peg,
Buried bumpers.
yeah, buried bumper syndrome. So
Yes.
that you should be able to identify. So this is the actual peg tube. It will have a plastic inside, not a balloon. If you have a balloon, it is peg replacement tube. Okay. So buried bumper syndrome is one of the complications of peg placement. Okay. Yes. Next is identify this procedure. It's kind of looking like surgical procedure, but actually endoscopists are doing it as of now. What is it?
Transoral outlet reduction.
Yes, it could be transoral outlet reduction or anything else.
Suture.
Suture. Endosewing. Have you heard of endoscopic gastric sleeve?
Sleeve gastroplasty, yes.
Sleeve gastroplasty. Yeah, that instruments also look like this, where the greater curvature you start stitching and you reduce the stomach size. Okay, so stitching at few times is possible even endoscopically, and this is one of the example. Okay, this could be TOR, like transoral outlet reduction. What we are seeing is different, but what you should know is endoscopically stitching is possible. Apollo stitch is one of the instrument. Okay, there are various other companies, but basically where you can hold on and stitch inside the stomach like this. Okay, identify this pain pattern. B
is colic.
Yeah, you see the colicky nature of pain, right? That is the most common type of crampy pain that we get. Okay, what is this? D
is catastrophic.
Catastrophic, acute, severe. What is C?
C is constant, progressive.
Constant and progressive. What is A?
Is resolving.
Progress and resolving. But just to get the discussion going, This is a patient who comes with vomiting and nausea. Identify the sequence. Chest X-ray showing something in the left side, and endoscopy, they have shown the fundus. And are you guys able to see the last picture also? CT scan. Yeah. What are you guys seeing?
Paraesophageal hernia.
Paraesophageal hernia.
Paraesophageal hernia. You see the gastric fundus seen here?
Yes.
Excellent. Now, what is it? Can anybody explain to me the endoscopic view? What you are seeing? What is that 20 and you are seeing the scope again? Part of the
View.
Yeah, for few students, it's called as retroflexed view. Okay, just to make the concept easy. See, this is a stomach. Okay,
Yes.
in the stomach, the scope turns around itself and projects and sees. Okay, so this area is seen. So you will see the entry of the stomach.
Yes.
It's like a selfie picture. That is the easiest way to see. So very few places where we see our scope picture. One is fundus, one is while we examine internal hemorrhoids, we tend to take a selfie of the scope itself, where the scope is entering. Okay, that's a simple way to put it. Okay, so here what you are seeing is, the scope also enters here and there's a rent here. So something is going that way. That is paraesophageal hernia. And this is a clearer picture where you see that this entire thing is going into the thorax. Okay, guys, are you with me?
Yes, sir.
Yeah. Volume of water absorbed by jejunum. So these two things have been marked.
6 liters and 2.5.
8.5 total. So 6 liters and 2.5 liters. Excellent. So that's the amount of water that is actually absorbed in the jejunum and ileum respectively. Okay. Now, what is this new device? Identify this procedure being done for a patient with fecal incontinence. Excellent. Endo flip. What does it measure actually?
Pressure or luminal pressure.
Anal distensibility.
Distensibility index. Based on the distensibility index at any sphincter area, you can tell whether it is distensible or not, or it doesn't contract. Okay. It can also be used for any sphincter, so you can also use it for achalasia cardia. Just like how you told Eckhart score, even distensibility index can also be used to assess the post-poem, how much relaxed it has become. Okay?
Yes, sir.
Are you guys with me? Just this much is enough to identify. To be more specific, for the esophagus, whatever you use the instrument, one of the instrument, it's called as esoflip. Okay?
Okay.
What is this particular tracing and what is the green tracing specifically?
Wireless capsule motilities.
Yes, that is the best answer. Wireless capsule for motility. So what does the green?
Green is for pH, sir.
Yeah, it's written here only. Green actually is for pH. Okay. So one, you can detect pressure readings. Second, you can detect the temperature. And third, you can also detect the pH. You see that the entire capsule seems to be quite long in the intestine. Now, in the colon especially? So probably this patient has colonic inertia. Okay, it's a kind of slow transit.
Slow transit. Yes.
Yeah. So how do you identify the different transit is a change in pH? Okay, you see this? The green thing actually moves from acidic to alkaline. Again, there's a change in pH. Okay, that's the way you identify the transits. Identify the procedure being done, and what do you actually identify in the first picture? There's bleeding going on.
Bleeding going on. Okay.
So you have inserted one clip, then you have inserted one more clip. So you have clipped it. Then see there's no bleed. This is one way of achieving hemostasis. Okay. So what is being done is hemoclip.
Yes, sir.
Are you guys with me? Yeah.
Yes,
what is this? This you see in a patient with UC. Identify the
Gangrenosum.
pyoderma gangrenosum. So extra-intestinal manifestations of IBD should be known. Please go through the table well. And one more question that you should know is, what are all the extra-intestinal manifestations which go parallel with the activity of bowel and what are independent of the activity of bowel? Are you guys with me?
Yes, sir.
Yes.
Excellent. What is this? In the elbow, itchy lesion in an elbow, where do you find it?
Celiac disease.
Celiac disease, it is dermatitis herpetiformis, but mechanism wise, it is slightly different. What is the mechanism here?
ITG.
Deposition at the dermoepidermal junction.
Excellent. What antibody is here?
Anti-TTG3.
TTG3. Okay. So again, a recent question in your theory exam, TTG2, TTG3, TTG6, three things were asked, correct? What is this?
Pharmacobazar.
This is a pharmacobazar. Excellent. Very good. So no also management of trichobazar. Okay. Surgery is a treatment. Of course, endoscopic management also can be tried. Corrosive injury, grade and name.
Sarga 3, there's necrosis.
There is necrosis, so it is directly 3B. 4 is
Perforation.
perforation. That then they'll show some other picture. CT, perforation, patient is sick, all that history will be given. So Sargar classification. Just to reiterate few things. What are you seeing in a patient with dysphagia?
Eosinophilic esophagitis.
What
Following
are
an
you seeing? Exudates. Excellent. Furrows and exudates. Okay. Candida illa. It's not Candida. Candida is slightly more different. Candida has slight. Okay. How do I describe it? There'll be something like this, but you will never get this. You saw this? This pattern is not seen. Okay. Candida will look very similar like this. Be very careful. If you find clear-cut lines or feline esophagus-like things, it is eosinophilic esophagitis. If not, it is candidiasis. What classification you use for endoscopic classification of candidiasis?
4C grade.
4C grade. Okay, for candidiasis. Okay. PET CT in a patient with GIST. Where do you find the lesion?
Liver mets.
Yeah, liver mets are there. Are you able to see them? Yeah, in the CT scan, can you see the lesion here? Excellent, guys. So, patient with glucogonoma, what are you seeing?
Necrolytic migratory erythema.
Necrotic migratory erythema. Excellent. Why does it happen?
Due to decreased amino acids.
Super. I was thinking some of you may answer some other mechanism. Okay, excellent. In AIDS cholangiopathy, what lesion are you seeing down? What is this anyway? What picture does it represent?
ERCP.
Why are you telling ERCP?
I agree with endoscope. That endoscope is there.
See, endoscope is like this. It is turning. Fluoroscopic picture you are seeing. They have inserted a dye and you are seeing the bile duct.
Okay.
This bile duct is enlarged because it is almost the size of the scope, which in itself is almost 1 centimeter. Okay. And see, it's kind of beaded.
Yes.
There's some narrowing here also. Okay. So AIDS cholangiopathy itself has 4 to 5 patterns on an ERCP, that is the cholangiogram. So go through that. What classification it is called?
Name, sir.
Yeah.
Just know the classification.
You might not know it. Just know what are the different types. You can have something called as papillary stenosis. You can have extrahepatic biliary obstruction, intrahepatic biliary obstruction, or combination of any of these. Okay. Cambridge classification is for chronic pancreatitis, not here. Here it is Sellos classification. You may know it. It might not make any big difference. What is the diagnosis on this histopathology? Yeah, what is it? Yeah, this one is amyloid. Apple green is there, so directly amyloid. What is this in the liver?
Florid duct. Yes. Onion skin.
Where do you see it?
PSC.
Yeah. What is the classic feature of PSC? Is it onion skin appearance? Pathognomonic feature.
Necrotizing non-suppurative duct lesion.
Yes. Non-suppurative cholangitis or bile duct lesion is pathognomonic, not onion skin appearance. Okay. Great.
Okay.
Florid duct. Non-suppurative cholangitis. What about in a patient with CLDE? See, I'm finding some scope here. I'm slightly retroflexed. And this is what I'm seeing in the body, fundus and body of the stomach. What are you seeing?
PHG, snake skin.
Yeah, see snake skin appearance, or what you call as mosaic skin pattern.
Yes.
So this is portal hypertensive gastropathy. Excellent. All of you know it. How do you grade it?
Great.
With red color signs and without.
Yeah. So if there is red color or subepithelial hemorrhages, it is severe. Otherwise, it is mild. Okay. So you have two mild and severe. You don't have moderate here. Huh? This has red appearance, with red sign, without red sign. Okay. Okay, what is this image that you're seeing on the lateral section of this patient, probably who has come with a history of pain, abdomen, angina kind of a feature after having food?
Median arcuate ligament.
Medial arcuate ligament syndrome. Excellent. Are you able to identify the picture, what's happening?
No, sir.
Yeah.
Celiac compression.
This is aorta. Are you convinced with that? This is spine. This is a lateral section. Sagittal view. That much you are convinced?
Yes.
What is the first branch of celiac artery? What is the first branch of aorta?
Celiac.
Celiac. Don't you? Is it a straight line or something has happened to it?
Oh, it's curved.
Curved. What's happening? Something is kind of constricting it from outside.
Yes.
So what is it now? This is how you try to know what's happening. Okay. So it's a sagittal picture. What you're seeing is celiac artery being compressed by median arcuate ligament. Are you guys with me?
Yes.
Super.
Yes.
Now this, what are you guys seeing here? This is a picture of a patient who presented with vague abdomen discomfort. I can't give more history, then it will become very simple. Are you able to identify it's MRI or CT?
CT.
CT. I'm confusing you. What is it, MRI or CT?
MRI only.
MRI. Sir.
It's MRI. See the vertebra, yeah? Can
CT.
MRI show this kind of vertebra?
CT, sir.
Yeah, it is CT. It's a simple CT where the bone is seen like this. Okay. See the bone, you can tell whether it's MRI or CT. Next.
Mass encasing the aorta.
Mass encasing the aorta is seen. See, they have only pinpointed. So that is why I tell Schlesinger, just flip through the pages. You will get all this in due course. Okay. So some kind of fibrosis or structure is encasing aorta. This much, if you are able to see, that is enough. It can be anything, any form of retroperitoneal fibrosis which can do this. Most likely IgG4 disease. Okay.
Yeah. Yes, sir.
You see this entire thing, aorta is there and something is going around it. Are you able to notice now?
Yes, sir.
Super. Okay, what is this picture? CT or MRI? First question.
CT.
CT. Super. So patient has abdomen pain. He has undergone some GI procedure. What are you saying?
Air.
Superb, man. Superb.
Surrounding.
You are seeing air surrounding the kidney.
Right.
Kidney. So retroperitoneal.
Yeah. So ERCP has been done and perforation has happened. Okay. Don't expect air under the diaphragm in a post ERCP perforation cases. Most likely this is what you will get. Okay. It's a perinephric air, that you get in these patients. Then again, they'll go into Stafford's classification. How do you manage? Okay, great. That's why I've told this. So we are not looking at diaphragm here. We are looking at perinephric air in ERCP.
Management is surgery only, sir.
Management depends. Suppose lateral border or medial border is gone, big rent is there, surgery is the management. If sphincterotomy and mild perforation is there, you can manage conservatively with antibiotics and see how the patient is. Keep him NPO and manage. If guide wire perforation is there, it is microperf, give IV fluids, antibiotics, manage conservatively. Okay?
Yes.
Depends. What's the type? Patient has, perforation. Most of the time it goes into surgery, but you can manage medically based on what is the rent, how big is the rent. Okay. This is a barium swallow showing Shatsky's ring. Okay, guys. You see this? Dr. Kashim has already answered. So sorry, I didn't give you time to think, but I think it's a straightforward question. Shatsky's ring. Okay. What is this Claus plot showing you?
Jackhammer.
Why are you calling it jackhammer?
DCI is more than 8,000.
GCI is more. You see, it's so much continuous. No, these patients would have definitely had chest pain, significant amplitude of the peristalsis that you get to see. Okay.
Yes, sir.
Same thing. I want to just give you in a picturesque way. Normally, after a swallow, you get it like this and something like this. Okay. So lower esophageal sphincter, lower esophageal sphincter will relax, and this will be how it would normally look. Okay.
Right,
I'll give
sir.
you 3 scenarios. Suppose it's more vertical. What are you thinking?
Distal esophageal sphincter.
Contraction.
Second, you have this thing, but you have a straight line. You may have parallel lines, or you have
Type 2 achalasia.
types of achalasia. First is type 1. Second is where you have 2 lines or 3 lines just parallel to each other. 3 is where you have this. Okay. In one picture, all the 3 types of achalasia is shown. What is this? The slant has become more vertical.
Distal latency has decreased.
Yeah, exactly. So what is it?
DS.
DS.
Okay.
DS.
Just to see and identify. Look at this D. It looks like this L part of the D. It's instead of slanting, it's more straight. The DL is reduced. Okay, guys. These are just to immediately identify after seeing a slide. Okay. Here, what's important in achalasia is this thing doesn't contract at all. I mean, it doesn't relax at all. So it is like a continuous line. Okay. Are you with me?
Yes, sir.
Yeah. That's a very simple approach. Yeah, identify what has been used in this procedure. Something has been done. What is it?
EMR.
Imaging.
EMR.
ESR.
ESD.
EMR or ESD?
ESD.
Yeah. So what is being done here is, do you see a lesion here in the G junction?
Oh,
So probably that particular lesion has been removed it in a nice way. They have not shown you all the steps, but when you see the specimen, do you see nice spotters around it? So first you mark the lesion and then do ESD. Okay. Now what? Yeah, something like this. See this. What is the type of resection you see here in this picture?
ESD.
Yeah, ESD. EMR is nothing like polypectomy. Okay, if you remember a simple polypectomy, how you cut and remove it, no? Now that will become EMR. Okay, for a bigger lesion. But for even bigger lesion, more like somewhere around 1.5 to 2 centimeter or much more, we might do a procedure called as ESD, where you see submucosal dissection is being done. Are you guys able to identify it? First, they mark the lesion like this. Are you able to see this? And then they get beneath the lesion and remove it. Okay. This is stitching or in the form of clips. There's a big rent, so that has to be approximated. That's what is being done. And after some time, see, entirely it is sealed after healing. Okay. This is a procedure. This is the rent has been closed, and after healing, this is how it looks bit time. Are you guys with me? These are the different types of clips that are used. You need not know every thing, but basically identify the clips. Again, you have different types based on different companies. That may not be important. Now, what are you seeing here? There is a bleeding vessel here.
Oh, Vesco.
Yeah, this is how it looks. Okay. This will be put around like a cup around the scope. We go there, suck the tissue, and then there's a mechanism to entirely grip the tissue like this. You got it? So after deploying, Ovesco in the tissue will look like this. Okay, over the scope clip. You just briefly see Ovesco. You should be able to identify it. Ovesco clip. Are you guys with me? What instrument is this? This is something like a gun, right? See here, some dilator, something fluid filled. See here, you have passed a guide wire, then you are dilating something. Then you see after that the narrow part has got dilated. See after dilatation how it looks. So what is the kind of dilatation you are seeing here?
Pneumatic dilatation.
Pneumatic is here. Here you are putting some
What
fluid.
is that?
CRE dilatation.
Okay.
Continuous radial dilatation, and you're using fluid. Don't mention the word pneumo because you are seeing bubbles here. Okay, I'll show you that picture also. Yes, you're convinced it's fluid.
Yes, sir.
It's not pneumatic. It is CRE. This is pneumatic. See, next slide only is yours. This is specially done for achalasia cardia. Before all this poem and came endoscopically, this was used to dilate the lower esophageal sphincter. You see this specialized narrowing so that it can easily get across the tight lower esophageal sphincter.
Yes, sir.
And then you dilate it pneumatically. Got it? What picture are you seeing here?
Filling ERCP, filling defects
Yes.
in the common
This is
bile
an
duct.
ERCP. This is the bile duct. You have filling defects here. Then this is balloon. When you retrieve the balloon across the CBD, this is how you will find the endoscopic picture. Got it? All the stones would have come out when you retrieve with the balloon. Got it? Entire procedure has been shown in just form of pictures. So this is basket. Sometimes with balloon also we can retrieve, or sometimes just with this we may retrieve. Okay. See, with this also stones may come out. Got it? Yeah. Now this is a hematological abnormality in a patient who has...
One preferred over the other, so the basket versus the other one preferred over the other?
No. First step is usually what we do is balloon. Okay. Balloon is the first preferred. If sometimes sharp stone, balloon you don't have, we may prefer basket. Balloon is preferred over basket. But the life of a basket is more than balloon. And it's cost effective. Okay.
Okay.
Yeah. This is an image of what you guys know already. I have told how to identify CT. You see the bone, CT scan. Okay. Now, this is a patient who has some form of hematological abnormalities, skeletal defects, and a short stature. Arrow there is showing a pancreatic region. It's not seen. It is like ghost pancreas. Nothing is there. So, what are you dealing with?
Schaumann diamond.
Common diamond.
Yes. So, pancreatic agenesis, Allah. Pancreas has got fully replaced by... Okay, fat looks hypodense, right? Okay, Swatchman diamond is the answer. Now, this is a question where, again, just to go from basics, you have a CT scan, you see the bone, and then you see the two kidneys, then you see the pancreatic region, you have some lesion here. What are you dealing with? This is gallbladder. Okay, this is gallbladder. This is a normal liver, segment 5. This is segment 5. This is gallbladder. This is a lesion that you're seeing. So, what are you seeing here?
Head, probably.
Yeah, there is some lesion there, probably head. It looks mucinous. It's worn.
Mucinous.
Yeah, it looks like
IPM.
Adenoma. IPM is difficult to tell in this picture. It looks like mucinous adenoma. Okay.
Heterogeneous.
Yeah, heterogeneous, big. Simple picture. What is it?
Stones.
Yeah, filling defects. Don't tell stones. Filling defects on cholangiogram. It may be stones. Once you do ERCP and see it, it is calculi. Okay.
Okay.
What is this picture?
PSC.
PSC. Multiple stricturings and dilatation of the biliary.
Multiple stricturings and dilatations, pruning, beading. So it is PSC. What is this? Is there a stone in the distal CBD?
It's a balloon.
Yeah, it is a balloon. So it looks like a balloon, right? So some of you may confuse it to be a stone. It's an occlusion cholangiogram. Okay. That is a preferable term. You do an cholangiogram by occluding the CBD by a balloon and putting the dye above it. So you have a clear delineation of the secondary bile ducts also. Okay. This is
also the same thing, sir.
Huh? Yeah, cholangiogram is also the same thing. Many times you may not see everything like that. See here, this is a normal this thing. Occlusion cholangiogram is when after we remove a stone, we put a balloon and then give a contrast to make sure that the entire CBD has been cleared. Okay. In that process, sometimes diagnostically we may get PSC. But now remember, one thing you should take home from this table is please don't do ERCP for diagnosis. Okay. MRCP is the preferred test for diagnosis in these kind of patients, especially like PSC. ERCP is now, because of its associated complications, is never used for diagnostic procedures. This is again a stone being retrieved during an ERCP. We can see a dilated ampulla through a side view scope. Okay. Identify the malformation here. Different types of malformation. Abernathy's malformation type 1.
1A, 1B, 2.
2 is where you actually have a proper shunt. Okay.
Yes.
That is important. See, 2 just looks like a shunt in itself. So shunt is actually there in 2. Side to side shunt. Okay. See this? Got it? What is the difference between type 1A and 1B? Small differences. If you guys have read, listen.
Portal vein is present, portal vein is absent.
There are more
portal vein is completely absent.
other congenital malformations and associated type 1A.
Okay.
1A and 1B difference.
Yeah, more abnormalities are associated with 1A. Okay. Next, what is this CT or MRI?
Hemochromatosis.
MRI.
Yeah, see, MRI. And then next question is, see, you see few bile ducts, they're all looking white. You see the gallbladder, it is looking white. Correct? This entire thing is liver.
Yes.
So what is it, T1 weighted or T2 weighted?
T2.
T2, because you are able to see the bile duct like it's water. Correct?
Okay.
Yeah. Even the spinal fluid, you see?
Okay.
Yeah. Understood, it is T2 weighted. What contrast do you use it here?
Nothing.
Adoxate.
Remember, when I'm talking about T1, T2, no contrast. If there is contrast, we will specially mention contrast is used to enhance something. Okay. So if you see this picture, you will think like something has been put. That is why gallbladder is seen, bile duct is seen. No, the nature of T2 imaging per se is you will see it like this without any contrast. Okay. Yeah. Now, basic things of MRI I have told. In this picture, especially why I have put it, I had done a mistake when I was shown this in my DM interview days. Basically, this is a picture of a patient who presented with some form of portal hypertension and advanced fibrosis of liver. On doing MRI, directly the radiologist called and told that there is an diagnosis made just by this picture. What is it? Because I had a similar case history with what had happened to us. Can you guys tell me the diagnosis just by seeing the picture?
Hemochromatosis.
Hemochromatosis.
Great. How do you tell that?
Liver looks jet black because of the iron.
Super. This is what is thinking out of the box. Okay. You see the liver compared to the spleen. It is hypo-intense. Correct? That's because of the diffuse iron overload that is present. So this is a case of hemochromatosis. Are you guys with me?
Yes.
Okay. So see, I'm putting this picture not for diagnosis. You should be able to identify first it is MRI. Second, you should have been able to identify it is T2 weighted image. Third, it is hemochromatosis because it is hypo-intense when compared to spleen. So when you talk it out in front of the examiners, you should be confident in telling about these wordings. Okay. So when I see a CT, I am never using the word hyper-intense, hypo-intense. I'm using hypodense, hyperdense. The word I use there is dense. Okay. When in MRI, I use the word intense. So you should be able to use the same in front of examiners also. Don't get confused. Okay.
Okay.
Suddenly they will ask you what contrast has been used in this picture to see the bile duct well. Don't tell gadolinium. No, T2 weighted image, it should be seen like this. Okay, guys, are you with me?
Yes, sir.
Yes, super. Okay, this is something. See, each time I don't go through these pictures myself. I just clear it up and come with you and discuss with you so that even I have to think along with you. Go ahead. What is the picture? Is it X-ray, CT, MRI? What is it?
CT showing some
CT scan.
internal septations.
Superb. Internal
Hydrated.
septations. Water, hydrated. Excellent, guys. I think most of you might be busy with choice filling, right? Sorry, it's one of the student. Okay, fine. So all of you have filled your choices in neat yeses?
Yes, sir.
Done. Okay. That's why few of you are still confused. So I'll have to get back to them now in a while. Okay, guys. So what are you seeing here?
It's hydrated cyst.
It is a cyst. It is a CT scan showing a cystic lesion which is hypodense with internal septation. Diagnosis?
Hydrated cyst.
Best one more thing. Is it a plain picture or is it with contrast?
Plain.
Plain.
Why are you telling it's plain?
Aorta.
Aorta not enhanced.
Aorta is not enhanced when compared with the bone. Okay. So it's a plane. In plane itself, you are seeing septation. So it is hydrated cyst. Okay, guys. What classification you use to identify them? Garbi or WHO.
Yes, yes.
This is what, again, CT scan. There is some contrast because it's inhomogeneous, but what are you seeing? It is in some form of some phase where the aorta and the IBC look similar, right? So it is a portal phase. What are you seeing?
Portal cavernoma.
See this area. This is portal cavernoma. So portal cavernoma cholangiopathy is what you are seeing in this patient. Got it? Are you guys with me? CT scan,
Yes.
portal phase, portal vein cavernoma. Okay. What picture are you seeing? What's the combination of all this picture? This is a fluoroscopy of some procedure that is being done. What is it? It is not gastroenterology doing it. It's interventional radiology doing it. First clue.
Tips.
Yes, tips is being done. I just to briefly tell you guys what is happening. See, once the contrast has been taken, you see the portal vein. Then you see the collaterals. You see all the collaterals here. Yeah. So then what happens? Through the hepatic vein, they come here and try to put a stent. And once after putting the stent, can you see the collaterals are no more taking up the dye? Are you guys with me? Tips.
Yes, sir.
So please go through about tips, indications and contraindications. Okay. Okay. Very common picture. They might ask you, what is going on in this bleeding patient? See, there is something bleeding here.
Spotting.
Yeah. So there is spurting going on from varix. We have gone and put a band. You see this black color thing around this? After banding and wash out, you see how it looks? This is how it looks after a varix is banded. Are you guys with me?
Yes, sir.
So this procedure is called EVL, endoscopic variceal ligation. Okay, this is a nice picture. Is it MRI or CT scan?
MRI.
MRI. So now that must be known now. Okay. Now you see the spinal fluid.
Yes, T2.
And you see the bile duct. You see the gallbladder.
T2.
This is more than gallbladder. This looks like a lesion. Okay, fine. Are you guys able to see this much? T2
Yes.
lesion. They have also mentioned. So I'm telling you how to analyze it. So there's a lesion which is T2 dense. T1 hypointense. Okay. You don't know what it is. Now you have to give contrast and see. After you give contrast, you see this lesion, arterial phase, aorta, how it is taken, venous phase, how it looks, delayed venous, washout, capsular enhancement. Okay. HCC. Are you guys with me?
Yes, sir.
Yes, sir.
Okay. What is this? Gastritis and omphalocele. Know the differences. Okay.
Yes, sir.
What is this, guys?
Video capsule.
Video capsule. Be able to identify. This is not an endoscopy picture. This is a video capsule. So it looks like there is water and some capsule is going inside the intestine and taking photos. Okay, that's how it looks. So it won't be well dilated with air and all. This is how it will look. Okay, so you see different pathologies here. Here there's an also aphthous lesion here. Here there is a submucosa, there is a proliferative growth. You guys got it? So this entire thing is for different patients. They have done capsule endoscopy. Okay,
Okay.
superb. What is this, guys?
It is.
C. diff. This is pseudomembranous colitis caused probably by C. diff. Okay. So recently go through about guidelines. Of course, few important points. It's already been mentioned. No metronidazole. Fidaxomicin may be even better than Manco. FMT and IMT when you use it. IMT is the new name for FMT. Toxins can be used as an adjunct along with standard therapy.
Yes.
These are the 4 points I wanted to tell you guys with respect to C. diff. What picture is this? Somebody answered it long back to me. Sorry, I'll just clear it up.
SB tube.
Blakemore tube, if you tell, the purpose of this picture is correct, but there are different types of SB tubes. This is one type of it. Okay.
Okay.
See the number of ports. There are 2 ports. Okay. And 2 balloons.
Okay.
Okay. Here also there is a port. Got it? There is here one port here also. So what is it? Now you think that.
Sengstrom Blakemore.
Sengstrom. That is why I have put up this picture. Okay. To just tell you how to identify the pictures. Sengstrom Blakemore tube will have 1 gastric balloon, 1 esophageal balloon. That's it. Okay. Remember, the 3 ports that Sengstrom Blakemore tube has is esophageal, gastric balloon, and gastric suction port. 3 ports. Got it? So there are 3 ports. SB tube. Okay. When it comes to Lincoln Nicholas, it has only 1 balloon. Remember L for lonely. There is only 1 balloon. Just by saying, you should be able to tell Lincoln Nicholas. If you see 2 balloons, it can be SBT or Minnesota. But Minnesota has 4 ports. Okay. What are the 4 ports that it has? It has gastric suction port, gastric balloon inflation port, esophageal balloon inflation port, and esophageal suction port. So you inflate and you do suction. So totally 4 ports. So this is Minnesota's tube that you have. Are you guys with me now?
Yes.
Yeah. Just to quickly see and identify, I purposely didn't put SB tube because it should be a wrong answer so that next time you guys will be right. You know what is Linton Nicholas? You see just 1 balloon, you know it's Linton Nicholas. It's lonely. SB tube, SB tube. It has 3 words. Remember 3 ports. Minton Nicholas, I remember as it has 2 ports and 4 ports. Minnesota's 4 ports. Okay, just quick revision. That's why I'm telling all these tricks. What is the new picture? This was added. Abvisor. Abvisor is a picture. This is a new instrument which is used to diagnose what?
IAP.
Yeah, abdomen compartment syndrome. Okay, Abvisor instrument used to measure intra-abdominal pressure. What is this, guys?
Balloon.
Can be Obalon, you are right. Or it can be a new one called as alluvion. Okay, ellipse. Where these are all swallowable and it distends inside the stomach and it itself goes in 4 months. Okay, so this is ellipse balloon by Allurian Technology. These are swallowable balloons. Recently, I have just put up a nice picture telling you differences between different kinds of balloons in the group. So you guys have seen it, no?
Yes, sir.
Yeah, that will tell you which is swallowable, which is non-swallowable, which among the balloons is actually having gas instead of liquid, which among the following balloon will require endoscopic removal and which will dissolve itself and get excreted in due course. So these are the minor differences that you have to know between the different intragastric balloons. Next is, you all know that we do something called as endoscopic ultrasound. In endoscopic ultrasound, we do a procedure sometimes called as FNAC or FNB. B is where you get a little core tissues. Core tissues, the advantage is it will help us take a core IHC and also helps in having an architecture of the tissue, and else it helps in diagnosis. That's the difference between FNAC and FNB. So what are the different stains that are used? For air dried, we use Jimsha stain. Alcohol fix, we use pap smear. For cell brock, we use something called a cytolite. For rose is nothing but rapid on-site examination, where we take the tissue, immediately put in the microscope, and we have a pathologist beside us to tell the tissue is there. There, toluidine blue is used. Take a screenshot, go through it in your free time. Okay. What is this? If you guys have done it, you would know. You need not be a gastroenterologist to do it. Maybe few of you guys have done it in a surgical wards. This is called proctoscope. What is this?
Wilson Cook. Band ligator.
Band ligator. Okay, this is a band. This is how band will look. See, there are some bands which are put over the scope. Each time by pulling the trigger cord, one band will be released on the varus. Okay. What is this?
Dilators.
Dilators. Savory. What's the full name of it?
Avery Miller.
Savory Gilead. Okay. SG. So these are used to dilate strictures in the esophagus. Okay. Are you with me? What is this? Tip of an instrument accessory which we use for something. This is nothing but a sphincterotome. Okay. Where the ampulla, you hook it like this, and you give it electric shock. Not shock, actually. You give it current passes across it and cuts the tissue in this aspect. You got it? So you cuts the ampulla. Are you guys with me? So last instrument again. This is SG dilator. Okay, Sejal. This is sphincterotome. This can be of multiple types. I'm grossly telling you how to identify if such things are shown. What is this?
Pneumatic dilator.
Pneumatic dilator. Excellent. So I had showed you this before, but then again you see it in practical thing. What you do under fluoroscope, you are going to put it across the lower esophageal junction and then dilate it. Okay. That's about it. These are different types of stents that you can get. What are the different stents you see? You see this is a plastic stent. This is an uncovered metal stent. This is a fully covered metal stent. This is a partially covered metal stent because the tip of the stent is not covered by the cover-like material. Okay. This is straight stent. Sometimes you can have double pigtail stent like this. That will be called as double pigtail stent. Okay. Don't go into too much depth with respect to stent size, this and that. At your level, it's not required. Yeah, it is the capsule endoscope is there. No, you saw the pictures of what this collects. But this is how it actually looks before giving it to the patient. It's like a big capsule compared to the tablet capsule. Normal thing which we swallow sometimes. Okay. So it's kind of 2 to 3 times bigger than the capsule, medication capsule. Okay, guys. Now this is the proper PEG tube which I was talking initially about. Okay. PEG tube. Okay. Now there's no confusion. You see this bolster? That's the plastic equivalent. It's called round bolster. That is what is usually present in the first time PEG tube that we place. Okay. Okay, these are new slides which I've added after last year's questions, the last year's. Now, what is this report?
Elastography.
Yeah, this is basically a fibroscan report where you have two things. One is cap and one is stiffness measurements. So there are different measurements to tell what is normal, what is not normal. In between the rib, they see the liver and try to tell the stiffness of the liver and the steatosis. Steatosis is measured by cap and stiffness is measured by KPA. Okay, guys, are you with me?
Yes, sir.
Yeah. So this picture you should know. Fibroscan is one company. Other company is what's called as FibroTouch, where you again have something like CAP and you have kPa. Two numbers are given. One is for steatosis, one is for stiffness. Stiffness is more of fibrosis. Okay. So if you want to go in detail, you can know that Fibro Touch is from one company. FibroScan is from the other company. Both the devices have very simple same principle of transient elastography. This much you should know. Okay. New kid on the block is electrogastrography, EGG. Okay, where you put 3 catheters, surface electrodes, and these are some of the readings. You have normal bradygastria, tachygastria can be diagnosed with this. What are you actually measuring? The pacemaker activity of the stomach. Okay, is what is seen here. Are you guys with me?
Yes, sir.
Some important trials, just whatever I could note down. With pancreatitis fluid management waterfall trial, we've been talking about it. With respect to obesity, you have a drug like semaglutide, where STEP trial, reduce is for reshaped duo, SMART trial is for Obalon, SPATS is for SPATS adjustable balloon, MERIT is for ESG trial, MERIT, endoscopic sleeve gastroplasty. For pancreatic fluid drainage, some trials are Panther, Tension, Miser, Pointer. For NASH, you remember for pioglitazone and vitamin E were used in PIVENS trial. Regenerate trial is for obeticholic acid. Resolve It trial is for alafibrinor. Cenicriviroc is Aurora trial, and Celonosertib is Stellar trial. Take a screenshot, read it, try to say it once, remember it, it should be easy. Okay, for IBD, go through Harrison's table, it is good. For HCC, there are some trials. One thing which I had told was, of course, SHARP trial is for sorafenib, which was used before. Reflect trial is for lenvatinib. Resource trial is for resorfenib. Regorafenib. Celestial trial is for cabozantinib. If you don't know any of this, it is still fine. Checkmate trial is for nivolumab and ipilimumab. Keynote trial is where pembrolizumab was used. I Am Brave trial is the one which completely changed atolozumab with bevacizumab as first line. Okay. One more trial which is more recent is Everest trial. Read about it. Durvalumab. Okay. Statistic question, I've already mentioned to you guys. Know how to measure sample size, what is receiver operator curve, what is number needed to treat, test of significance, per protocol analysis and intention to treat analysis, Kaplan-Meier curve, forest plot, mesh graph and other things I've just mentioned some time ago, and your thesis well. Okay. So no need to postpone. We don't have any class tomorrow. Whatever doubts you have, please put up in the group. Whenever I can, few of the other friends might be able to answer your questions. Okay, guys. Good luck. All the best.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you.
I want to tell you few important things. Don't overwork yourself. Everybody are in same boat. It's about your confidence, how you speak. Try to classify. If you know, you know. If you don't know, tell you don't know. It's okay. You have still not done DM. Even after DM, we may still not know. Okay. So it's fine. All of you are in this stage, not because of fluke. All of you are prepared quite well enough to reach this stage. Okay. So good luck, guys.